Good morning, everyone. I would like to warmly welcome you all to this advanced implantology workshop organized by Department of Oral and Maxillofacial Surgery, Nims Dental College and Hospital. Nims University, Rajasthan was established in 2001 and enacted in 2008 by Government of Rajasthan, one of the leading universities in India and the largest self-financed university in Rajasthan. Is structured as a composite model university. The university is heading towards a leading center of education in health sciences to human sciences, technical training to advanced engineering, personal to corporate management, creative literature to innovative multimedia, art and architecture, offering more than 450 courses, preparing young minds for a better tomorrow. Nims Dental College and Hospital, the college was established in year 2006 with a committed intention of furnishing quality dental service to the society through distinguished dental training of the young aspirants. With latest technologies and excellent faculties and modern dental education, the key objective of the institution is to provide quality service to the nation through the medium of science and education. Following these objectives, our Department of Oral and Maxillofacial Surgery has emerged as one of the main surgical departments in Nims Super Specialty Hospital, and more than 150 surgical cases under general anesthesia has been done in last 16 months, which includes facial trauma, orofacial pathologies, TMJ surgery, and facial aesthetic surgery. Our department is one of the main faculty in emergency department as well. And now we are taking one step ahead. For the very first time, we are going to organize an advanced implantology workshop. Now, I would like to thank Dr. Balveer Singh Tomar sir, Chairman and Chancellor of Nims University, for making it possible to organize this workshop for the betterment of students. He has conveyed his best wishes for this workshop. Now, we'll start by welcoming our guest on this stage. First of all, I would like to call upon stage Dr. Amit Kumar Sharma sir, HOD of Oral and Maxillofacial Surgery, and Dr. M.K. Sunil sir, the Principal of Nims Dental College and Hospital, to come on stage and welcome our guest. Our chief guest could not be available today, so I would like to request Principal sir and HOD sir to welcome our chief guest of honor, Dr. Chaman Ram Verma sir, Dean Faculty of Medicine and Allied Sciences. I would request Principal sir and HOD sir to welcome our guest of honor. A big round of applause for Dr. Chaman Ram Verma sir.
सामने हटना
Now, I would like to draw your attention to our guest speakers. A big round of applause for them. First, I would like to call upon stage Dr. Narendra Bansal, Head and Professor of Department of Dental Surgery in R&T Medical College and Hospital, Udaipur. And I would request HOD sir to welcome and felicitate our guest speaker, Dr. Narendra Bansal sir. Now, I would like to call upon stage our next guest speaker, Dr. Nishant Gupta sir, Head of Department of Oral and Maxillofacial Surgery, Jaipur Dental College. A big round of applause for them. I would like to call Dr. Vikram Sharma sir, Professor of Oral and Maxillofacial Surgery, Nims Dental College, to welcome and felicitate Dr. Nishant Gupta sir. A big round of applause, everyone. Now, I would welcome our special guest, Dr. Rajesh Sharma and Dr. Rajiv Sharma. And I would request HOD sir to welcome them. I would also like to welcome our Head of Department and faculties of Nims Dental College to this workshop. Thank you for your presence. Let's begin this workshop with lighting the lamp in front of Goddess Saraswati. So I would like to request our guest of honor and principal sir and our guest to come up on stage and light the lamp.
Mobile.
Thank you, sir. Now, I would request Dr. Amit Kumar Sharma, sir, Head of Department of Oral and Maxillofacial Surgery, Nims Dental College and Hospital, to say a few words.
Good morning to all students, our HODs and हमारे डायरेक्टर सर, प्रिंसिपल सर. सर एक्चुअली मेरे को ज्वाइन किए हुए अभी महीना 15 दिन ही हुए हैं, पर उसके बाद आने के बाद में मेरे को जो ये फील हुआ है कि यहाँ आने के बाद में पहला प्रोग्राम हमारे डिपार्टमेंट में मैंने प्रपोज किया प्रिंसिपल सर को, तो उन्होंने कहा कि करिए. इससे पहले मैं चमन सर से मिला था, तो चमन सर ने कहा कि नहीं ये तो होना ही चाहिए. तो जो सपोर्ट कॉलेज और यूनिवर्सिटी दिया है उसके लिए बहुत ज़्यादा धन्यवाद चाहता हूँ. और बहुत ही शॉर्ट नोटिस में हमारे प्री बॉस डॉक्टर नरेंद्र बंसल और डॉक्टर निशांत गुप्ता ने मेरे प्रपोजल को इमीडिएट स्वीकारा और उनका कोई दिक्कत नहीं है, हम आ जाएंगे. उनके लिए बहुत बड़ा धन्यवाद है कि उन्होंने मेरी बात को रखा. और स्पेशली मैं थैंक्स देना चाहूँगा डॉक्टर राजेश शर्मा और राजेश सर को कि वो यहाँ आए हमें सपोर्ट करने के लिए. एंड स्पेशल थैंक्स टू आवर न्यू प्रिंसिपल डॉक्टर M.K. सुनील सर. ही इज ए बैकबोन फॉर मी. व्हेन आई स्टार्टिंग द प्रोग्राम आई वाज थिंकिंग कि होगा कैसे होगा. उन्होंने कहा नहीं हमें करना ही है, मैं हूँ तुम्हारे साथ में, कहाँ चलना है, मैं साथ चलता हूँ. कम से कम 4 से 5 बार ऑडिटोरियम का चक्कर उन्होंने खुद ने हमारा हर चीज़ को देख कर गए. तो मैं बहुत ज़्यादा धन्यवाद करना चाहूँगा. और आगे मैं कोशिश करूँगा कि हमारे डिपार्टमेंट की तरफ से और अच्छे से अच्छे प्रोग्राम हो. और जो स्पीकर हमने बुलाए हैं रिनाउंड स्पीकर हैं, आप उनको सुने और वो जो काम कर रहे हैं उसको सीखने की कोशिश करें. धन्यवाद.
Thank you, sir, for your kind words. Now, I would like to call upon Dr. M.K. Sunil, sir, the principal, Nims Dental College and Hospital, to say a few words.
Good morning to all. Respected Chaman sir and other dignitaries, head of the faculty members and the speakers. It gives an immense pleasure to you and today's the CD program. I think first of all I congratulate to Dr. Amit for taking an initiation to conduct such a program on the lecture. It is not a joke to organize such an event in a short notice time. The speakers, arrangements to made of the thing and the live demos and other technical issues, etc. So I thank to our chairman sir and the technical team who has come forward within a short time and organized such an event in a huge way. When Dr. Amit and has come to me to say about that he will do it in a in a state level. So I didn't agree for that. So it has to be done in a pan-India level. So now there are 6 states who are going to involve all the oral surgeons as being postgraduate students are involving this particular online. And there are certain people who also came from different parts of the college and visited here to attend this particular CD program. We have called the best renowned speakers, Dr. Naren and Dr. Nishant, who are the best one in their particular field. I think definitely the students will enlighten about the knowledge of the advancements in the implantology. I think every student should know about this is a bread butter to all the dentists when you go for the practice. So definitely these people will talk about the various advancements in the field of implantology, and they will share their knowledge to you, and definitely you the students definitely can observe what they are going to do and what they are going to perform the live surgeries. And the students who have been online will use the benefit of this particular event. And I thank to the support of all the given by the management and the thing, and I thank sir Dr. Chaman sir who has been accept our invitation and to grace the occasion. And thanks to all the people who are all the supported students and the delegates who have been behind this program. Thank you.
Thank you for your kind words, sir. Now, I would like to request Dr. Chaman Ram Verma, sir, our guest of honor, to enlighten us with his words.
respected Principal Sir, respected Dr. Narendra Bansal, guest speaker, Dr. Nishant Gupta Sir, head of the departments, faculty members and students. Good morning to all of you and welcome in this function. I am very happy to be here that Department of Oral Maxillofacial Surgery is organizing workshop on advanced implantology. I think with the best possible speakers, faculty and students will enrich their knowledge. And this is something very good start. Other 8 departments should also take initiative like this. All the best for this function and all the best for Deepavali also. Thank you so much.
Thank you for your kind words, sir. Now, I would welcome our esteemed guest, Dr. Anumeha Jain, and I would like to request Dr. Vikram Sharma, sir, to welcome her. Please come on stage, ma'am. A big round of applause, everyone. Dr. Anumeha, ma'am, from Head of Department of Anesthesiology. Now I would request everyone to stand up for national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए तब जय जनगणमंगलदायक जय हे भारत भाग्य विधाता जय हे
Now we are starting off with our lecture session. I would like to request Dr. Narendra Bansal, sir, to come up on stage and start with the lecture.
टेबल कुर्सी हटा दो
बोलना पड़ेगा।
ये वाली कैमरे पे जो लाइव चल रही है,
कौन सा?
ये वाला लाइव से जाती है, आप लोग देख लेंगे।
इसको बता दो।
हेलो।
ये कैमरे पे जाएगा जो लाइव जा रहा है।
अच्छा,
इधर से वो तो हैंड माइक
हैंड माइक लाओ ना यार, हैंड माइक लाओ, ऐसे कैसे काम चलेगा। ये ना ना बिगनिंग
सर, वो यहाँ हैंड माइक है क्या? हैंड माइक जो पोडियम माइक चल रहा है उसका कोई हैंड माइक है तो दे दो, कोई हैंड माइक से।
मेरा लैपटॉप लूँ क्या? वो लैपटॉप देना बॉस, अपने वाले से कुछ प्रॉब्लम है। इसमें वो स्लाइड शो नहीं बता रहा। हो क्या? पेन ड्राइव निकालती कैसे हुई? हो गया? इस पे तो नहीं आ रहा। हो गया? अच्छा, इस पे नहीं दिख रहा हूँ, है ना? बोतल लाऊंगा, पानी बोतल देना प्लीज।
Hello. A very good morning to all of you. I am very thankful to Nims administration, especially Dr. Bala, for providing me this opportunity to speak on dental implantology, basics of dental implantology.
वो माइक वो नहीं है क्या? हैंड वाला माइक, कॉर्डलेस।
यहाँ खड़े खड़े बोलना तो बड़ा मुश्किल हो जाएगा.
कॉलर माइक से
ये कॉलर माइक एक्चुअली इज नॉट अटैच टू
वो जो
दिस हॉल.
माइक जो लगाया ना मैंने, वो आपने लाइव जो जा रहा है उस माइक पे आएगा, और वो कैमरा पे आएगा और इसमें ऐसा नहीं सुनने की कैमरा पे आएगा.
So no problem. We start with the lecture. Kindly switch off the light. The screen is visible to all. Too many switches in the hall, like too many complications in the implant. So we are here to discuss about the basics of dental implantology. So first of all, I want to ask a question to all of you, whether the title of this topic is okay or not. Basics of dental implantology. As an academician, it seems okay, but as a hardcore clinician, I think the topic should be more comprehensive. Like this. The basics of replacing the teeth made by dental laboratory for the patients with the help of dental implant. So here, so many people are involved. Number one is patient. Number two is your laboratory person. Number three is yourself who is operating. And the implant company which is providing the implant to you. Because patient comes to us for the replacement of the tooth. He or she is not coming to us for placement of dental implant. So as per the patient is concerned, the main thing from the patient side is the only expectations of the patient. So we have to fulfill all the expectations of the patient. For that, it is not functioning actually properly, this laptop. For that, we have to consider the general health of the patient, oral health of the patient, dental health per se, occlusion of the patient, habits of the patient, bone of the patient, and of course, because we are doing a surgery, so we have to consider the blood also and the medications taken by the patient. So all these things keep in your mind when you are planning for a dental implant patient. Next thing is इसको निशान देखना यार, जो स्लाइड यहाँ चल रही है ना वो वहाँ नहीं चल रही.
बार बार चेंज करना पड़ता है.
इसको हटा दो यार. मैं वही आ गई. हाँ ठीक है, मैं इधर देख लेता हूँ, इसको छोड़. ओके. So when we are planning for the patient, we have to plan for the teeth. We should have a prosthetic plan in our mind. we should think about the available space for the placement of the implant and for the replacement of the tooth, and of course impressions, prosthetic kit and the prosthetic components which we need for the prosthetic rehabilitation after placement of the implant. Now we need an implant to put into the patient's mouth, so we should all know about the implant. What is the macroscopic geometry is there, microscopic treatment is there for the implant, how is the internal hex, how is the prosthesis going to be fit on the implant. Now we proceed for the implant first. What is the implant? Implant basically is a structure which is inserted into the patient's mouth, either beneath the mucosa or beneath the periosteum or inside the bone or traversing the bone to the other cortex. So accordingly we have submucosal implants, subperiosteal implants, transosseous implants and corticobasal implants. So we are here today to discuss endosseous implant, in which we insert the implant, and this implant will engage first cortex and the cancellous bone of the patient. So these are the armamentariums which we require for placement of the implant. Physio dispenser, implant surgical kit, blah blah blah, long list is there. So one by one we will take up. Physio dispenser, what is a physio dispenser? Physio dispenser basically is a torque motor. It converts the speed energy into the force energy. You can understand it by reverse thinking, like something is rotating at fast speed and you want to stop it. So if you try to hold it to stop, the amount of force which you need to stop it, that is called torque. So here up to 35,000 RPM per minute speed is there. That speed we can adjust on the physio dispenser, and accordingly we can also set the torque. So 100 Newton centimeter torque is roughly equal to the 10 kilogram of the force. So how we change the speed into the torque? We need a reduction handpiece. So in implantology usually we are doing endosseous implant with the 20:1 handpiece. Here you can see a X-ray of the patient, in which you can see the radiolucency around the implant and a radiolucent area around the implant. Why it happens? Because of the high insertion torque. So torque should be used very judiciously. Up to 35 Newton centimeter, 45 Newton centimeter torque is enough for the placement of the implant and for getting the primary stability. So it is not wise to use very high torque while planning for endosseous implants. This is iFix company surgical kit. Most of the companies are supplying such kind of kits, in which we have two kinds of drills. First drill we use, that is called as pilot drill, that is a very sharp drill, and another pilot drill is known as Lindemann drill, which is having facility for apical drilling as well as side drilling. So what is the advantage of this drill? Lance drill, we can make a purchase point for drilling with the help of lance drill, and if we feel that we have to change the direction of our drilling, then we have to use the that Lindemann drill, which is side cutting drill, because it is cutting on the sides also, so you can change the direction of your placement. Another drills are cortico-cancellous drills, which are usually used progressively to increase the size of your osteotomy, and never try to use these drills to increase the length of the osteotomy. If you want to increase the length of the osteotomy, always use side cut drill before using the corticocancellous drills. Another thing in the kit is parallel pins. Parallel pins are basically used to check the parallelism when most of the time when you are placing more than one implant, like 2 implants you are supposed to place. So you drill first for the first implant, then you can put a parallel pin on that osteotomy, and again parallel to that parallel pin you can make a new hole parallel to the previous one. Another important thing in the kit which you should have, that is drill extender, especially when you are doing a immediate case. What happens in the immediate case? You have adjacent sides, there are teeth, so short drill cannot drill up to full length whatever you required, so that you have to increase the length of the drill, so drill extenders are used for that. Hex drive is a universal tool in the every kit which we use to tighten up the cover screw, tightening up the or loose, removing the healing caps and putting the abutments. This hex drive is used. Fixture driver, wherever I say fixture or implant, it is one and the same thing. Some people say it fixture or some people say it implant. Fixture driver means the instrument which drives the implant into the osteotomy. Depth gauge is there, by which we can judge the length of your osteotomy, how deep you have drilled, so you can use the depth gauge. And one more beautiful product in this kit of iFix company is the drill stoppers. So you have drill stoppers of various lengths. By putting, like if you put 6.5 millimeter length stopper, so your osteotomy will be only up to that 6.5 millimeter, not more than that. So these are the drills from iFix company. You can see the lance drill in the picture, side cut drill, then sequential drills for further increase in size of the osteotomy, that is 2 mm, 2.4, 2.8, and all there is an interval of 0.4 millimeter. So basically you are increasing the osteotomy size very gradually, so that you are not overheating the bone. And here the lengths are written as per the implant size provided by the company: 7.5, 8.5, 10, 11.5, 13 and 15. These are the drill stoppers. We can put this drill stopper to the drill, so that you can get a length of 6.5, 7.5 or whatever you require. These are the cortical drills. What is the use of these cortical drills? Because every bone of our body is lined with a very thick and hard bone, that is cortical bone, and inside there is a cancellous bone. So cortical bone is very hard, non-compressible in nature. So whenever you are planning, like in the mandible anterior zone, or if D1, D2 bone scenario, there is no compressibility of the bone, so you have to slightly increase the cortical site osteotomy. So for that you can use these cortical drills on very low speed. This is drill extender. These are the parallel pins. This is depth gauge, by which you can check the depth. This is the fixture or the implant driver. Here in the picture you can see the handpiece, 20:1 handpiece, quadrangle handpiece, and there are two kind of fixture driver. One is for handpiece, another one is for ratchet. This is hex driver, and these are the various pictures in which you can see the implant. After placement of the implant, we usually use the cover screw, second one. Third one is the healing cap, which we use for the making the gingival collar around the implant. Then further we go for prosthetic components. We have to take the impressions. So in the fourth one you can see two pieces. One is open tray impression coping, lower one is the closed tray impression coping. then you go to make the model. So 1, 2, 3, 4, 5, fifth number is the implant analog. So what happens, the impression coping comes in the impression, and in the impression you put this implant analog and then you pour the cast. So what you will get in the cast, that is implant analog. On that implant analog you can fix any kind of the abutment from this list. One is the direct abutment, another one is the castable abutment, third one is the UCL abutment, and fourth one is the multi-unit abutment, and fifth one is the angled multi-unit abutment. Like angled multi-unit abutment, you may have angled this one, angled direct abutment, and last one is the prosthesis. So I am going okay, or are you understanding everything? Because I was told about this presentation that most of youngsters and before trying to start their implant practice, so I have made this presentation for them only. Most of the senior people also listening me. I pardon before them if I go wrong. So these are the images from the patient, in which you can see the healing caps are there after the placement of implant, and once we remove the healing caps, what we see is the gingival collar around the implant. It is very much mandatory for the implant to be successful long term, to be surrounded with a thick band of keratinized soft tissue, and at least 2 to 2.5 millimeter your implant crest should be below the soft tissue crest. So here you can see the X-ray in which implants are there and healing caps are there in the picture. These are the impression coping in the patient's mouth. These are the open impression copings in the patient mouth. Then, because there are 3 implants and we don't want any of the impression coping to be moved from their respective positions, so what we do is we tighten up, we tie with all these 3 with the help of floss, dental floss. After joining these with the dental floss, you can put that flowable composite or pattern resin to join all these 3, so that there will be no micro motion. After that, we took the impression. This is the impression which is showing you with these impression copings, and this is the impression after placing the implant analogs on that. This is the model in which you can see the direct abutments are placed. These are basically angled abutments, because in maxilla most of the time we have to direct our implant in the palatal direction, so you need most of the time that angulated abutments. After placing the angulated abutment in the patient's mouth, we can put prosthesis on it, and we finished our case like this. These are the direct abutments we can see in the patient's mouth after placement of implants. Basically, this picture was taken after removal of the temporary prosthesis, so you can see somewhere we can see the cement is there on the implants. I am sorry for a dirty picture. These are the multi-unit abutments. These are another kind of abutments which we use in full arch cases, because by the virtue of these abutments we have so many advantages. We will discuss about these advantages in the forthcoming slides. Now, when we are planning for a replacement of the tooth with the implant, this is my checklist. You can also follow it. First of all, the most important thing is to check the mouth opening of the patient. This is especially true for those consultants who are doing their visiting practice to the other clinics. Sometimes dentists call for the implant placement. Bone is okay, everything is okay, X-ray is okay, CBCT is okay, but when you reach to the clinic and see the patient, there is no mouth opening. So how will you check the mouth opening? You take your handpiece, contraangle handpiece, put the longest drill in it, and now put into the patient's mouth and do up and down motion. Check whether you are getting space for the movement of that handpiece. If there is a space, then it is okay, and if there is no space, then something do other thing other than implant, because as I said before, patient comes to us for the replacement of the teeth, for not the implant. In a less mouth opening, somehow you can manage your implant, but you can't manage your prosthesis because your impression copings are too long, and you have to tighten up the impression coping in the patient's mouth, and after putting the rubber base impression material on that, and after setting, you have to remove the impression coping from the mouth also. So in the impression is in the mouth of the patient, that impression coping is there in the mouth, so you can think how difficult it is to remove that impression from the mouth if there is no sufficient mouth opening. So it is very important to check for the mouth opening first. Another thing I suggest all of you, whether you are endodontist or any kind of practitioner, always go for a checkup of TM joint before starting any treatment. Usually what happens in the practice, like if the patient comes to you with a toothache and there is a pre-existing temporomandibular joint disorder and patient is unaware about it. Now what happens? You do the root canal treatment and you are doing a single sitting or 2 visit. Most of the time you have to have spent 30 minutes with the patient with open mouth. So what happens? The condition exaggerated. Then again what happens? Next day morning patient calls you, सर जिसमें आपने रूट कैनाल किया था उसमें बहुत ज़्यादा दर्द हो रहा है. अब आप सोच रहे हो कि मैंने सारी पल्प निकाल दी, मैंने DMP बहुत अच्छे से कर दी, दर्द हो क्यों रहा है? पेशेंट झूठ बोल रहा है. लेकिन पेशेंट कभी झूठ नहीं बोलता. पेशेंट, whatever the patient is saying to you is the 100% truth. If you are not understanding, it is your fault. It is my personal experience. So always check for the TMJs, because again implant placement is a long surgery, prosthetic treatment is a long appointments are there. So always palpate the TMJ, check for any noise, check for any subluxation, any sign of internal derangements, and take a history of trauma to the joint. Suppose the patient comes to you with a history of unilateral condylar fracture, long back. What you can suspect from that patient? You will have definitely a problem with the prosthetics, because on the side of the fracture, if it would have been managed with a closed reduction protocol, you will see the less Rama site on the side of the fracture and a proper Rama site on the contralateral side. So you have to have consider this if a trauma patient comes to you. So always check for these things. Now what usually we miss is the allergy. Whenever you are planning a implant case, always take a history of, if a lady comes to you, you can ask for, is there any allergy from these artificial ornaments, because most of the artificial ornaments are containing nickel and prosthetic components and other lab copings are made with the nickel film. So the patient may have allergy. Even titanium allergy may be there, and it can be the signs of titanium allergy are the erythema, urticaria, eczema at the site of your placement of the implant. And if you are having implant failure with no other reason in your mind, then consider the patient may be allergic to the titanium. Now, as I said before, the mouth opening, the second one is the space availability. Check for the space intra-arch as well as inter-arch. So we need at least 1.5 millimeter distance from the adjacent tooth and 3 millimeter inter-implant distance, 2 millimeter distance from the vital structures. So keep these things in your mind. Now we come to the oral health. Always examine the patient for oral hygiene, periodontitis, any active infection, periapical, periodontal, bone pathologies, malignancies or any history of malignancies, mucosal disease or precancerous conditions in the mouth. Like if there is a missing lower first molar in a female patient, and at the same site if you see the lichen planus lesion, I will not go for an implant in that case. Definitely you can plan at your level. Check for metabolic bone pathologies and irradiated jaw. Irradiated jaw is the contraindication for the placement of the implant, but most of the corticobasal implantologists are doing implants in the radiation patients also, but definitely it is contraindicated before 6 months because of the low vascularity of the bone. Dental health, check for supraeruption, tilting of the adjacent teeth, occlusion, special mention for the tongue thrust. The patient comes to you with proclined upper and lower anteriors with spacing. Always check for the tongue thrusting. Don't ever go for directly placement of the implant and immediate processes, because the implant will fail definitely. And after osseointegration, if you go for the prosthesis, you have to make it your teeth slightly proclined so that you can give space to the tongue. Otherwise the screw loosening, screw fracture and these kind of problem can occur in that case of tongue thrusting. Adjacent teeth status, always check. In edentulous space, what we do the implant, we do the crown, but we used to fail to check the adjacent teeth. Like what we do in the IOPA X-ray, if the patient comes and we take a IOPA X-ray for a carious lesion, what we see in the X-ray? By our habit, we just see whether we have to do the filling or the root canal, exposed or not exposed. But we are not thinking upon the canals, how narrow their canals are, how the curvature of the root is. So likewise in the implantology, we are focusing on only in the implant, the placement of the implant in what area, but we don't see the adjacent teeth. Suppose if there is a class 2 lesion in the adjacent tooth, you will place the implant, you will put the crown after 6 months. क्योंकि जो इम्प्लांट का जो पेशेंट होता है वो क्या होता है, उसको मैं बोलता हूँ दामाद जी, क्योंकि वो पैसे देता है तो वो आपका दामाद हो जाता है, वो किसी भी टाइम आ सकता है और आके उसके कुछ भी हो रहा होगा ना, घुटने में भी दर्द हो रहा होगा तो वो कहेगा यार डॉक्टर साहब जब आपने इम्प्लांट डाला तब से मेरा थोड़ा घुटना दुखता है। तो आप क्या है कि उसको कैरियस लीजन अपन भूल जाते हैं, देखते नहीं हैं, फिर बाद में जब पेशेंट आता है 6 महीने बाद, यार जहाँ आपने इम्प्लांट लगाया था ना वो खाना फंसता है। अब आप ये नहीं कह सकते उसको कि यार यहाँ पे कीड़ा लग रहा है, क्योंकि वो कीड़ा भी इम्प्लांट नहीं लगाया होगा। So these are very minor things, but if you keep these things in your mind, your path will be a highway. You will drive like a highway. Now very important, you check for the general health of the patient, bleeding disorders. On the top list, hemophilia. Beware of hemophilia. As a dental personnel, what we think these hemophilia kind of things are diagnosed very early in the childhood or in the initial puberty years. but this is not the case basically. Hemophilia may be diagnosed at the age of 40 years. The patient may have hemophilia B, or even in hemophilia A, there are variants. Some patients are having very low factor rate and some patients are having moderately low factor rate. So until unless he is not encountering any major surgery, the patient is difficult to diagnose. So keep bleeding disorders in your mind, keep the drugs which are affecting the platelet aggregation, etc. Diabetes mellitus, hypertension, congestive heart failure, MI, parathyroid hormone, thyroid, epilepsy, asthma. Asthma is also important because you have to schedule your patient late in the day. Never call the asthma patient in early in the morning or at the evening hours, because there are more chances of asthma attack at this time. Chronic renal failure. Why we considering chronic renal failure? Because the patient may have dialysis, and in dialysis we use heparin. So these, and prostate malignancy. What happens in the prostate malignancy? They give a drug zoledronate. Zoledronate basically cause the osteonecrosis. So if a prostate cancer patient taking zoledronate comes to you, so beware to place the implant. Just ask to the oncologist before to adjust the dose of the drug or any sign of the osteonecrosis in the oral cavity. Now I will discuss bleeding disorders some in more detail because it is very important. First fear in our mind while we are doing surgery is only from the bleeding point of view. So you can ask 4 questions to the patient. Bleeding problem is there any history of bleeding problem in the relatives? History of spontaneous bleed? Any history of prolonged bleeding after any surgery? Use of antiplatelet or anticoagulant drugs? Past or present illness history? And a very important question, have you ever got your teeth extracted? Agar yes, कोई complication नहीं है, it means that patient is not allergic to local anesthesia and probably don't have any kind of bleeding disorder. So how will you check? You check for the platelet count, bleeding time, clotting time, prothrombin time, and activated partial thromboplastin time. Now, why all these 5? What happens with the bleeding when a vessel is ruptured? Then coagulation process starts, and it has 2 phases. One is intravascular phase, another one is the outside the vessel. Intravascular first reaction, what happens? Signal goes to brain that injury has been happened, and what happens to platelets? Platelets become sticky. They stick together as well as on the wall of the blood vessel. Another thing happens, vasoconstriction. At the site of injury, immediately vessel spasm occurs. So this is the initial mechanism, very initial mechanism for stopping the blood by the body. After that, coagulation cascade starts, and factors comes to play their role. So what cardiologists do in the CHF cases or MI cases, he is considering only the intravascular part. He is stopping the platelets to become sticky and agglutinate. So he is using the antiplatelet drugs. So what antiplatelet drug is doing? That antiplatelet drug will increase your bleeding time. So whenever patient is taking aspirin, clopidogrel, or any other kind of antiplatelet drug, or if the patient is alcoholic or patient with liver disease, always go for bleeding time checkup. Clotting time, you can suspect hemophilia if your clotting time is high, or there is a prothrombin deficiency, you go for clotting time estimation. But only doing by clotting time, you can't diagnose a hemophilia patient. It may be a normal in hemophilia patient if the factor VIII concentration is moderately low. For definitive diagnosis, you have to check for the activated partial prothrombin time. It measures the ability of the blood to coagulate by the intrinsic mechanism. So, in case of patient is taking aspirin, clopidogrel, heparin or dialysis patients, you always go for checking the activated partial prothrombin time. Prothrombin time, it measures the ability of the blood to coagulate outside the vessel. So whenever patient is taking heparin, warfarin, liver disease, long-term antibiotics, chronic alcoholism, malnourished, go for prothrombin time. Now let me ask you one question. How the long-term antibiotics are affecting your hemostasis? Dr. Boveja? How the long-term antibiotics are affecting the hemostasis? Because long-term antibiotics, what will happen? Your gut bacteria which are synthesizing your vitamin K will die, and there will be a vitamin K deficiency. So vitamin K deficiency will lead to the vitamin K dependent factors in your blood, and that can result into the increased bleeding diathesis in the patients. Now we have to consider the medications: bisphosphonates, insulin, inhalers, antiplatelets. If patient is having the inhaler, ask the patient to come with the inhaler. And these are few drugs, newer drugs which are used as antiplatelet drugs like ticagrelor, ticagrelor. These you can learn the name, or at least if patient comes you with the prescription of a cardiologist, you can see the drug name and you can judge is there any antiplatelet drug or not. Now we come to the next thing, that is CBCT. Most of time we see the patient's mouth and we check for the available bone by judging the width of the alveolar ridge. But this is not a correct method, because the soft tissue biotype of the patient differs very much. One may have a very thin biotype, so you may find a wide bone in that case. But if the patient's having the biotype very thick, so you can have a picture like this. Intraorally, this patient is giving the clue that there might be very much width of the bone will be available. But after doing the CBCT, what we see is very thin knife edge ridge is there. In this image, you can see this mylohyoid fossa and angulation of your mandible. In some patients, it is very acute like this. And this information is very useful. जैसे आप लोग इन्फीरियर एल्वेलर ब्लॉक लगाते हो, तो बहुत सी बार इन्फीरियर एल्वेलर ब्लॉक फेल हो जाता है. क्यों होता है वो? क्योंकि जो फ्लेयर है आपका मैंडिबल का, ये डिफर करता है, पर्सन टू पर्सन इट डिफर्स. यू कैन चेक योर सेल्फ टू ईच अदर. यू रन योर फिंगर ऑन द एक्सटर्नल ऑब्लिक रिज and go upward to this anterior border of the ramus. Always do this before giving any injection. Always do this. By doing this, you can judge the flare of that ramus, and according to that flare you insert your needle. Likewise, in the body of the mandible, the body of the mandible is inclined as lingually, so this inclination differs. Why it differs? Because our bones in the body are affected by the muscles. कोई लंबा चौड़ा आदमी आएगा बिल्कुल ऐसे मस्कुलर बॉडी वाला, तो उसका आपको हड्डी भी वैसी मिलेगी, बहुत प्रोमिनेंट आपको कॉर्टिकस मिलेंगे, बहुत एक्यूट एंगल्स मिलेंगे. तो इट इज़ वेरी इंपॉर्टेंट टू डू द CBCT. This third one picture is very important. Here you will find very good width, but in a X-ray you can't suspect this condition. This is not possible to judge with the only if we have X-ray, we can't judge it. Fourth is more important, most important. You may have any kind of odontom like thing. You also cannot appreciate it in the IOPA X-ray. So CBCT is must for placing the endosseous implant. In my words, always go for CBCT. Now beware of these vital structures: inferior alveolar nerve, maxillary sinus, middle superior artery branches, nasal floor, blah blah blah. Long list is there. In the maxilla, most important is the anastomosing branch of this middle superior alveolar artery. You may find this in the lateral wall of the maxillary sinus. So if you are doing a direct sinus lift, you should check for that in the CBCT. In this image you can see this anastomosing branch. And another important thing, if you are going for a pterygoid implants, so you should know that your pterygoid apophysis is placed slightly medial to the crest of your ridge on the most of the time. Mandible, only important thing which is very important is the anterior lingual artery. This you will see in the CBCT. Only CBCT can help you in this case. You can see two radiolucent lines here in the lingual side of this anterior mandible section. These are the branches of the anterior lingual artery which are entering into the anterior mandible here. What will happen if you drill and rupture this artery? Where the blood will go? Blood will go towards the sublingual area and it start collecting there and it will make a hematoma. And remember, there is no posterior boundary. Sublingual space की पीछे कोई boundary नहीं होती है. What is sublingual space? Mylohyoid muscle है, mylohyoid के ऊपर sublingual space है, mylohyoid के नीचे submandibular space है, बीच में mylohyoid है. It is also known as safety wall of your oral cavity. So blood collects in the sublingual space. The way to the blood is only towards backward. Blood goes and will collect in the parapharyngeal space. So this will interfere with the airway of the patient. So be cautious whenever you are doing implant in the interforaminal region in the anterior zone. Now we come to the another important structure, that is bone. अभी बोन में क्या है, अपने को बचपन से क्या है कि एक दिमाग में कंसेप्ट होता है फ्रॉम द स्कूल टाइम कि हड्डी एक ऐसी चीज़ है कि वो जैसे बन गई है एक बार, वो कभी बदलेगी नहीं और बहुत स्ट्रॉन्ग है और उसमें कोई बदलाव नहीं आने वाला है. लेकिन इस कंसेप्ट को अपने दिमाग से बिल्कुल इरेज कर दो, बिकॉज बोन एक बहुत ही डायनामिक टिश्यू है. बोन इज ए मोस्ट डायनामिक कनेक्टिव टिश्यू. By hour and hour your bone is changing by the process of remodeling. अभी होता क्या है, अपने को नहीं पता लगता, अपन दिन में बहुत सारे काम करते हैं, अपन साइकिल भी चला रहे हैं, भाग भी रहे हैं, दौड़ भी रहे हैं, कुछ भारी सामान भी उठा रहे हैं, तो छोटा मोटा जो टीयर एंड वियर अपनी बोन्स में भी होता है, माइक्रो क्रैक आ जाना या कुछ ज़्यादा लोड पड़ जाना किसी चीज़ पे, तो उसका जो रिपेयर है दैट इज़ कॉल्ड एज रीमॉडलिंग. एंड दिस starts before birth and this remodeling continues throughout the life. So please erase this concept in your mind and keep the concept that bone is very sensitive to the pressure and the torque. So bone is having the structure, protective, locomotor and mineral reservoir functions. It is having 80 grams at the birth, only 80 grams, and which comes to the 3 kilogram after 25 years. Dynamic connective tissue and having the compact or the cortical bone on the boundary and cancellous and trabecular bone inside that boundary. So the cortical bone is function is providing the shape, size and strength to the bone. Cancellous bone का क्या काम है? Cancellous bone is inside the cortical bone, protected by the cortical bone, and cancellous bone is acting as a reservoir of calcium. So basically, cortical bone is more mineralized. In words of implant surgery, cortical bone is more mineralized, non-compressible in nature, very vulnerable to the trauma, very vulnerable to the heat, etc. And cancellous bone is somewhat forgiving bone as compared to the cortical bone. So when you are drilling the cancellous bone, slight error की माफ़ी दे सकती है आपको वो, लेकिन अगर कॉर्टिकल बोन में आप ड्रिल कर रहे हैं तो बी कॉशियस एंड केयरफुल. सो व्हाट इज मॉडलिंग? मॉडल नहीं होते मॉडल. मॉडलिंग क्या होती है? किसी चीज़ को बनाना. तो मॉडलिंग एक ऐसा प्रोसेस है जो आपके बिफोर बर्थ स्टार्ट होता है और यूजुअली अप टू द 40-42 ईयर्स की एज तक चलता है. वो उसका काम क्या रहता है? आपका जैसे लोअर मैंडिबल कैसा है, उसकी शेप कैसी होगी, उसमें कोरोनाइड प्रोसेस होगा, उसमें कोंडाइलर प्रोसेस होगा, रैमस होगा, इंटीरियर मैंडिबल ऐसा होगा. वो जो शेप एंड साइज है वो डिसाइड करती है मॉडलिंग. once you have achieved your puberty age, early adolescent, every this modeling is completed, and now that modeled bone should be in that shape and size. This is done by continuous process of remodeling. So it is a continuous process, starts before birth, continues for the life, and it maintains the serum calcium, and it also follow the circadian rhythm. The remodeling is more at the night time as compared to the daytime, and is very much influenced by the hormones like calcitonin, parathyroid, vitamin D, estrogen, testosterone. And एक और मज़े की बात आपको बताऊं मैं कि जो ये रिमॉडलिंग होती है, दिस इज़ ऑल्सो अफेक्टेड बाय द एडिपोसाइट्स, जो फैट सेल्स होती हैं. तो जितने भी मोटे आदमी होते हैं ना, उनकी हड्डियां भी उतनी मजबूत होती हैं. सो this we have already discussed, cortical and cancellous bone. Most of the skeleton of our body is made up of cortical bones, and only 20% is cancellous. Now we have two things in our bone. One is collagen. Type 1 collagen is there along with other proteins, and mineralization, hydroxyapatite. अभी जो कोलाजन पार्ट है, that will give you the toughness in the bone. Toughness क्या होती है? To resist the fracture when load is applied. तो टफनेस क्या है? बच्चों में कोलाजन ज़्यादा होता है, तो बच्चों की बोन जो होती है टफ होती है, दे रेजिस्ट फ्रैक्चर. तभी बच्चे गिर जाते हैं, पड़ जाते हैं, लेकिन हड्डी को कुछ नहीं होता है. बट द मिनरलाइज्ड पार्ट व्हाट इट इज़ गिविंग द stiffness to the your bone. Stiffness means it will resist the bending. When you are apply the load, the bone resist bending because of mineralization. So नेचर ने कैसा बनाया सिस्टम कि जितनी भी अपने इंट्रामेम्ब्रेनस बोन्स हैं, लाइक इर्रेगुलर बोन्स जो होती हैं अपनी बॉडी की, वो ज़्यादातर इंट्रामेम्ब्रेनस होती हैं, जैसे वर्टिब्रा हो गई, मैक्सिला हो गया, मैक्सिला इज इंट्रामेम्ब्रेनस बोन। तो इंट्रामेम्ब्रेनस बोन आप जितनी भी देखोगे उसमें आप क्या है, कैंसलस बोन ज़्यादा होगी, कॉर्टिकल बोन कम होगी। व्हाट इज द क्लिनिकल सिग्निफिकेंस? मैक्सिला क्या है, मैक्सिला आपको थोड़ी इलास्टिसिटी देगा, स्टिफनेस देगा फॉर बेंडिंग एंड ऑल, बट मैंडिबल नहीं देगा आपको। क्यों? मैंडिबल क्या है, इंट्रामेम्ब्रेनस एज वेल एज एंडोकॉन्ड्रल अपोजिशन बोथ आर देयर इन द condylar region, because mandible comes into the class of long bones. If you make a long bone in horseshoe shape, it is called mandible. So long bones increases in length with the endochondral bone formation. So जितनी भी बोन ऐसी है जिनमें एंडोकॉन्ड्रल बोन अपोजिशन हो रहा है, वो यूजुअली स्टिफ होती है नेचर में, दे डोंट प्रोवाइड एनी काइंड ऑफ बेंडिंग, सो इट इज वेरी इंपॉर्टेंट। So maxilla is irregular bone and de novo formation is there, intramembranous, less cortical, more cancellous, comparatively soft, less mineralized, with more collagen and resorbs more as compared to mandible. And mandible is like long bones, length increases by the endochondral bone formation, more cortex, less cancellous, more mineralized, more resistance to bending, almost non-compressible. Now if you are an endosseous implantologist, means you are using a conventional implant, so you will engage first cortex and cancellous bone. And on the other hand, if you are a corticobasal implantologist, like Sari is doing corticobasal implants, you are dealing with cortical bone. And as a endosseous implantologist, you have to deal with the cancellous bone especially, not with the first cortex is very less. So keep in your mind that making the osteotomy in the cortical bone is very difficult. That is why they use very high speed, because speed automatically gives the torque to minimize the time for the drilling. You can drill it with the low speed also, but you will take more time to drill up to so much of length. Now these are the cells of, we all know there are three kind of cells, but important thing is not here to note is the osteoblast cell is the property of your bone itself, because it is coming from the mesenchymal cells from the connective tissue of the bone. But osteoclast is not a property of bone. Osteoclast कहाँ से आती है? Osteoclast blood से आती है, मोनोसाइट से आती है। मोनोसाइट जैसे सॉफ्ट टिश्यू में जाके मैक्रोफाइज बन जाती है टू रिमूव द डेब्रीज, टू रिमूव द अनवांटेड थिंग्स, सेम ऐसे के ऐसे ही जो ब्लड से जब मोनोसाइट बोन में आती है तो वो क्या बन जाती है? ओस्टियोक्लास्ट बन जाती है। एंड व्हाट इट डज, इट रिमूव द all the dead tissue, debris, and it is very important cell. Until unless osteoclast is not there, you cannot think of bone formation, because osteoclast will induce the osteoblast to make the bone, and also it will make the environment there neat and clean for a new osteoid formation. And what is the function of osteocytes? What happens when osteoid is deposited by the osteoblasts and gradually it get calcified? Some of the osteoblasts will die and some of the osteoblasts will be embedded in that matrix, and some of the osteoblasts go to the rest underneath of periosteum. This is the fate of osteoblast. So the osteoblasts, which are after doing their work, which are embedded in the matrix, they are called osteocytes. So osteocytes are very important for the signaling mechanism. One osteocyte here can give signal to your toe. It is how much you can think about of the bone, how much the bone is organized tissue. So this is important for, as per of the, we think about the implant. Implant is, we all know, we put the implant into the bone and it becomes integrated within the period of 4 to 6 months. This is a rough guideline. But what happens that this today, suppose today you are doing an implant and you have inserted the implant today. Now I want to tell you one thing. Between 20th day एंड 40th डे 20 से 40 के दिन में कभी भी इम्प्लांट को छेड़ना नहीं है अपने को, ना तो उसको कुछ खोलना है ना बंद करना है, कुछ नहीं करना है. बिकॉज शुरू के 21 दिन क्या होगा, योर जो उसकी आज प्राइमरी स्टेबिलिटी है जो आज आपने लगाया, दैट विल डिप डाउन. आफ्टर दैट आफ्टर 2 weeks around time, osteoid becomes to be deposited there and that will be calcified in the future days. It may take 200 days also, but most of the time in the healthy patient you can go for prosthetic phase after 3 or 4 months. But my message is never touch the implant between on 20th day to 40th day. Now this is there are two things in the bone when we think about of the bone for the placement of the implant. One is the quality and quantity. Quantity means how much bone you have, width, length, everything. And quality means how is the consistency of the bone. How much amount of cortical is there, how much amount of cancellous is there. And on the basis of this proportion, the amount of cortex and amount of cancellous, you have 4 type of bone: D1, D2, D3, D4. D1 is most of the cortical, very less cancellous. D4 is most of the cancellous, zero cortex. Among these two, there are 2 varieties, D2, D3. D2 is considered as the best bone for implant placement. Why not D1? D1 is very dense. It is very hard to drill. Heat production chances are more. So implant failure chances are more. So if you are planning for a 4 by 11.5 diameter implant in D1 bone, then you have to drill the bone up to the 4 millimeter diameter. You are not supposed to drill with a under osteotomy in the cancellous bone. So this is very useful classification, and by sending the patient for CBCT scan, you can get an idea of this quality of the bone from that CBCT scan. Hansfield unit can provide you the data about the bone status, what kind of bone is. So it is very important to note. Now we come to the quantity of bone. Quantity wise, there are again 4 divisions: division A, B, C, like this. Division A is wonderful bone, very good width is there, very much length is there. And last one is the D category, in which only basal bone is remaining, there is no height. So you can go through in the textbook like these things. Now we come to the implant. When you are going for an implant placement, before placement you should know everything about your implant system, what kind of implant you are using, what kind of kit is there. So I will give you an idea about this iFix implant. So when we see the endosseous implant, this is the endosseous implant. There are 3 parts basically: crest module, body and the apex. most important thing is the crest module. Why? Because it is giving the connection to your abutment. So iFix people are giving the implant with a conical Morse taper with a hex. So it is a very good connection. It avoids the micro motion, screw loosening, etc. And in the body there are threads. So different companies are giving different kind of thread designs. There as per the design of the thread is concerned, every thread has advantages and disadvantages. iFix company is giving the implant with the buttress thread. And microscopic surface roughness, most of the companies providing us with the endosseous implant with moderate roughness, because nowadays with the research and everything we have concluded that the moderately rough surface is better than the very rough surface or smooth surface for the process of osteointegration to be happen. So these are the different kind of the threads. You can see this is standard V thread which we see in the Ostem company, and these are the spiral threads you can see in the Bioline or any Israeli implants, and this is the iFix implant. In this image you can see the buttress threads. With the help of buttress threads, what is the advantage? The insertion of the implant is very easy. It fastly goes into the osteotomy, and very less, it do not put any kind of undue pressure on the walls of your osteotomy. And in this slide you can see the different kind of the methods by which we are giving the implant moderately rough surface. So rough surface कैसे बनाते हैं implant के ऊपर? सबसे पहला मेथड क्या था कि कोई हार्ड पार्टिकल ले लो, एल्यूमिनियम ऑक्साइड और टाइटेनियम ऑक्साइड और समथिंग, और उसका बहुत ज़्यादा तेज़ प्रहार करो उसके ऊपर ताकि वो उसमें पोरोसिटी डेवलप कर दे. लेकिन इसमें क्या हुआ कि पोरोसिटी तो डेवलप हो गई, लेकिन सम ऑफ द बम्बारमेंट एलिमेंट्स लाइक टाइटेनियम ऑक्साइड एंड एनीथिंग दे गेट एम्बेडेड इनटू द इम्प्लांट सरफेस. सो फिर रिसर्चर ने सोचा कि भी ये इसको कैसे हटाएं, तो फिर एसिड एचिंग का स्टार्ट हुआ कि आफ्टर बम्बारमेंट यू पुट द इम्प्लांट इनटू द हैवी एसिड, सो दैट एचिंग भी हो जाएगी और जितनी भी ये इम्प्योरिटीज़ हैं वो भी हट जाएंगी. तो इस तरह से जो सरफेस अपने सामने आई उसको SLA सरफेस बोलते हैं. तो ये जो अपना iFix इम्प्लांट है इसमें भी SLA सरफेस है. एंड नाउ इट इज़ most of the endosseous implants, what are the features you need in an implant? You need a conical connection, you need a hex for stability, you should have a platform switching, you should have a moderately rough surface with, and many other companies are also giving with anodization and etc. This is a very long topic, but keep in your mind that these implants are moderately rough. Implant connection I have already told you. This is the iFix company implant. You can see in the image buttress thread engine for the superior primary stability, and coronal bevel is there. This is the coronal bevel which gives it inbuilt platform switching. What is platform switching? This is the diameter of your implant, this is your implant, and this is your abutment. ये बॉटल जो है ना, ये दिस इज एग्जैक्ट एग्जांपल ऑफ प्लेटफॉर्म स्विचिंग. प्लेटफॉर्म इतना चौड़ा है लेकिन अबटमेंट कम चौड़ा है, इससे नैरोअर देन द डायमीटर ऑफ द क्रेस्ट ऑफ द इम्प्लांट. सो ये क्या करेगा? दिस विल गिव अपॉर्चुनिटी टू द एडजेसेंट सॉफ्ट टिश्यू टू कवर दिस डिफेक्ट. सो बाय डूइंग दिस व्हाट वी आर डूइंग, वी आर इम्प्रूविंग द सॉफ्ट टिश्यू मार्जिनल सील. So platform switching is there. Sorry. मैं सोच रहा था इतनी देर से फ़ोन कैसे नहीं आया. So what it do, Actually, it reduces the stresses in the bone at the both crestal and cancellous level just because of its design. Another thing in this implant is it is having the single prosthetic platform for all the diameters. Like if you use 3.5 diameter implant or you use 4.5 diameter implant, any kind of diameter you have used, but it is same for all abutments. You can put any abutment to any implant. So what happens with this kind of feature? Inventory will be less. There are companies which are providing diameter specific connection. So in that case, you need lot of inventory. For every diameter of implant, you should have a same kind of matching abutment. Topographically, the iFix implant having the large grit sandblasted are available in every company most of the time. The direct straight, direct means which is given by the company. Like the tray, we have stock trays and we have customized tray also for taking the impression. So the tray अपने पास आती है perforated stainless steel, that is called as stock tray. The abutment which is company giving you is the stock abutment, which is in the stock abutment. What is the advantage? Advantage is shape, size, polishing, everything is standardized. So because the collar is very much polished, your soft tissue health will be very fine. But what is the disadvantage? You may not find any particular angle. Suppose you have 15-degree abutment with you, but you need 20-degree. So in that case, what to do? You go for UCLA abutment. What is UCLA abutment? This is a abutment like this. ऊपर पूरा प्लास्टिक होगा, बेस पे मेटल होगा, बेस मेटल क्या होगा? जब इसकी कास्टिंग करेंगे तो जो मोल्टन मेटल है इस बेस मेटल से जुड़ जाएगा, तो आप उससे किसी भी एंगल का अपने हिसाब से अबटमेंट बना सकते हो. या फिर अगर आपको कास्टिंग के चक्कर में नहीं पड़ना है तो यू कैन गो फॉर मिलेबल बार विच इज़ ऑल्सो गिवन बाय द कंपनी. इतना बड़ा सारा होता है बार, काफ़ी अच्छा खासा बड़ा होता है. वो आप लैब वाले को दे दो जिसके पास मिलिंग की फैसिलिटी है, वो अकॉर्डिंगली आपको उसके शेप एंड साइज़ में मिल करके दे देगा. अनदर थिंग इज़ द टाई बेस. टाई बेस इज बेसिकली very short kind of abutment is there of titanium on which you can fuse your zirconia crown on that. So you can make a screw retained crowns with zirconia with the help of tie base abutment. These are the different kind of prosthetic components. This is healing cap, this is impression coping, closed tray impression coping I think, and this is your implant analog. This is your direct abutment, again direct abutment, angled direct abutment. This is ball abutment for overdenture cases, and this is locator abutment again for overdenture cases, and these two are multi-unit abutments. What are these multi-unit abutments? As the name suggests, multi-unit means when you are doing a case more than a unit. Suppose you have placed 6 implants. Now on 6 implant you want a prosthesis, so you can place direct abutment 6, but it is very rare in a full mouth case that you place all 6 implants parallel. You may not have sufficient bone to place all the parallel, so you will angulate some of them. So what happens if you go for straight abutments? You don't have a full range of angles. So in the available angles, even after putting that, you are not getting the proper angulation. So to correct this, you can use the multi-units. Multi-unit से आपका एंगल करेक्शन का काम काफ़ी हद तक 99% सॉल्व हो जाता है. सबसे बड़ा एडवांटेज क्या है मल्टी यूनिट का? सबसे बड़ा एडवांटेज है कि आपने इम्प्लांट डाल दिया, उसके ऊपर मल्टी यूनिट अबटमेंट लगा दिया है, which is traversing your soft tissue. Now when you are doing a prosthetic phase, you need not to remove that multi-unit. So what you are doing, you are not disturbing the marginal seal of the soft tissue. So soft tissue health is always better with the multi-unit. Second advantage, जो कि बहुत बड़ा एडवांटेज है वो भी, जिसमें कि आप जो प्रोसेसेस बनाओगे वो स्क्रू रिटेंड बनेगा. तो एनी पॉइंट ऑफ काइंड, मान लो सिरेमिक फ्रैक्चर हो गया, कुछ टूट गया, तो इट इज़ ओनली 5 minutes टू रिमूव दैट ऑल द प्रोसेसेस बाई अनटाइटनिंग ऑल द स्क्रूज एंड रिमूव द प्रोसेसेस. थोड़ा लंबा चौड़ा तो नहीं हो गया, बोर तो नहीं हो रहे? थोड़ा तो हो गया, वैसे कोई नहीं. तो नाउ वी कम टू द सर्जरी. Surgery, it is just like a extraction of tooth, not too much, or removing the impacted third molar or any kind of impacted tooth. What we use a mucoperiosteal incision. We raise the flap, but in case of implant, you keep in your mind that don't raise too much of flap, because your alveolar bone is having the blood supply from your periosteum. So if you raise a wider flap, you will compromise the blood supply of the bone. So this is the key point. And after flap, you use pilot drill, and after pilot drill, you can use side cut drill to manage your direction. Then subsequent drilling, then insertion of fixture. Now, when you are inserting your fixture or the implant into the osteotomy you have made, एक रफ गाइड देता हूँ आपको मैं, कि जैसे आपने ऑस्टियोटॉमी कर ली, अब आप उसमें इम्प्लांट जैसे रखोगे ना, तो आधा इम्प्लांट अंदर चला जाना चाहिए, हाफ ऑफ दैट लेंथ. अगर वो आधा भी अंदर नहीं जाता, ऐसे 1-2 थ्रेड ही अंदर गए हैं, इट मीन्स योर ऑस्टियोटॉमी इज नॉट अप टू द मार्क. सो in that case, what to do? You use only cortical drill on the cortex, that's all. Then you can put cover screw or healing cap. If you are having good primary stability, you can directly go for healing cap, suture, call the patient after 3 weeks, 2 to 3 weeks time, and remove the healing. You can check for the soft tissue healing at that time. This is the drill sequence given by this iFix company. Lance drill at 1200 RPM, then Lindemann drill 1000, 2 mm 1000, subsequent drills on the low speed 6 to 800 times. These iFix company drills are very, very good drills in terms of, if you want to collect the bone from the osteotomy, you use only 200-250 speed. So what will happen? The drill will come with the bone. So that bone you can use for mixing with your xenograft. And then this is the last one is showing the implant driver, on which you put your implant and driven it into the osteotomy. Now we come to the complications. The common complications are bleeding, swelling, pain, hematoma, ecchymosis, infection, nerve damage. These all the complications we can avoid. As I said before, you can make a highway for yourself. If your pre-op workup is solid, you will not find any kind of complication. Till date, in my practice, other than failure of the implant, which are also very few, intra-op complication 0. There is no complication till date. No bleeding, no ecchymosis, nothing, no prosthetic problems, no screw fracturing, nothing is there in practice till date. I am fortunate in that, but keep in your mind that तैयारी जो है ना आपकी बहुत इतनी अच्छी होनी चाहिए कि वो गलती होने का कहीं कोई सवाल ही नहीं रही. So impressions basically there are two kind of impressions: open tray, closed tray, or one newer is the digital impression you can take with the help of scan bodies. Come to the prosthesis. Prosthesis may be cement retained or screw retained. We have discussed already. अभी सीमेंट रिटेन, स्क्रू रिटेन में एक चीज़ और ऐड कर देता हूँ मैं. कि you see your interocclusal space. Interocclusal space means the opposite arch tooth and your soft tissue margin of your planned side. You see the distance, that is your interocclusal space. If you have enough interocclusal space, always go for cemented prosthesis, never go for screw retained. In case you don't have sufficient amount of interocclusal space, means in which you are not having more than 4 millimeter of the height of your abutment, at least you should have 3.5 to 4 millimeter of the height for a cement retained kind of prosthesis. If you are getting less than that, then you go for screw retained prosthesis. Or if you are doing more than one implant, multiple cases, always try to use multi-units and screw retained prosthesis. The life is easy with these things. Now we come to the contraindications. As such, there are no contraindications. Relative contraindications indications are smoking, diabetes, cardiac diseases, etc. These we can manage. Absolute प्रीकैंसरस लीजन नहीं होना चाहिए जहाँ पे आप इम्प्लांट कर रहे हो उसके आसपास. इरिडिएटेड जॉ में थोड़ा केयरफुल रहना पड़ेगा आपको. ओशियस डिस्प्लास्टिक चेंजेस कहीं नहीं होने चाहिए. इसीलिए सीबीसीटी क्या है, सीबीसीटी भी आप अगर आपको थोड़ा सा भी सस्पिशन है कि 40 ईयर एज का पेशेंट है, अदरवाइज कुछ थोड़ा सा भी अगर डाउट हो तो आप उसका चाहे 2 इम्प्लांट डालने उसका फुल माउथ स्कैन करा लो, कोई फ़र्क नहीं पड़ता उससे. जो 50,000 खर्च कर रहा है तो वो 3,500 तो लगा ही देगा, 4,000. तो उससे क्या है कि आपको पता लगा कि आपने 6 में इम्प्लांट किया और 6 के जस्ट पीछे अमीलोब्लास्टोमा पड़ा हुआ अंदर, ये भी बन रहा है, तैयार है आपके लिए. वो तो आपको खा जाएगा, वो कहेगा आपने जो ये इम्प्लांट डाल दिया मेरे, तो ये बना दी बीमारी आपने. तो इस चीज़ पर दीज थिंग्स यू शुड कीप इन योर माइंड. सो ल्यूकेमिया इज एब्सोल्यूट contraindication for extraction also. Any kind of surgery, beware of that. Bisphosphonate therapy is basically nowadays it is a relative contraindication, not a absolute one. So now we come to few cases, only 3-4 cases I have. There is no full mouth case because Dr. Nishant will take a lecture on full mouth case. So this is a replacement of tooth number 11. So what should be the next slide? Dr. Rajiv boss, next slide क्या होगी? Take a impression, make a cast and place a tooth. By doing this you can have an idea कि यहाँ दांत लगेगा भी कि नहीं लगेगा, या लगेगा तो कितना चौड़ा लगेगा, कितना लंबा लगेगा. हंसती है पेशेंट तो गम्स दिखते हैं, कैसे करना पड़ेगा, ये सब चीज़ों का आपको आइडिया हो जाएगा. नाउ CBCT, this bone you can't see in the IOP X-ray or OPG X-ray. You have to go for this CBCT scan. So in every immediate case, what we do, we don't go in this direction. Will not go in this green direction. We'll go palatally to take the advantage of length. This is extraction. Do extraction very carefully in immediate cases to preserve your labial cortical plate. There was already dehiscence here. Perforation was there in the bone. Still I did not use any kind of graft because most of the time I am not in favor of grafts, because grafts मेरा एक्सपीरियंस ऐसा है कि ग्राफ्ट जो है ना मोर और लेस ज़्यादा कुछ करते नहीं है, इतना कोई विशेष काम नहीं करते हैं, लेकिन आपकी समस्याएं जो बहुत थोड़ी ज़्यादा बढ़ा देते हैं. वो इन्फेक्शन के चांस बढ़ जाएंगे और थोड़ा स्टेरिलाइजेशन प्रोटोकॉल आपको बहुत ही ज़्यादा स्ट्रिक्टली फॉलो करना पड़ेगा. मोर ओवर एलर्जी भी हो सकती है पेशेंट को उसके ग्राफ्ट के किसी कॉन्स्टिट्यूएंट से. तो जहाँ तक संभव वो मैं थोड़ा सा अवॉइड ही करता हूँ ग्राफ्ट वगैरह करना. ऑटोमेटिकली अपन टूथ को निकालेंगे. वी हैव टू कट द टूथ लॉन्गिट्यूडनली. We have to remove a small portion of the tooth. so that we can give a space for luxation. So always use very fine luxators to remove such kind of tooth. This is the osteotomy in the palatal side. It should be in the line of cingulum of the adjacent teeth, so that you will have the final position of your implant in the line of cingulum. This is the chair side fabricated temporary with the help of this flowable composite. What I do, I put direct abutment, then cover adjacent teeth with the Teflon tape, both sides, and put your finger behind palatally like this, and gradually flow your flowable composite and give it the light, and gradually you make it, then remove it, then finish and polish. Chair side. Here you can see the proximal areas of this crown. You have to remove too much of too much of composite from here, because you have to give the space for the interdental papilla. This is the temporary crown in the mouth, and this is the iFix implant, probably 15 millimeter long. This is after 4 months after removing the temporary. This is second case, 2526. Dr. Rajiv, boss, next slide. अभी क्या है, मान लो इसमें इम्प्रेशन नहीं लिया और अपन ने ये नहीं बनाया, तो होगा तो कुछ नहीं. हो सकता है कि 2 मिलीमीटर एक इम्प्लांट पीछे हो गया और 1 मिलीमीटर एक आगे हो गया, लेकिन उससे क्या है कि लैब वाले को बहुत प्रॉब्लम आती है. लैब वाला फिर वो कॉपिंग कहाँ बनेगी उसकी, दांत कहाँ बनाना है उसको, तो थोड़ा ऐसे करने से थोड़ा आपका क्या है कि अच्छा, ऐसा करने में ऐसा नहीं है कि जो अपन ने आरपीडी बना लिया और वहाँ छेद कर लिया और वहीं ड्रिल करना है. आपको आरपीडी बनाना है, आपको छेद भी करना है सेंटर में, फिर आपको के फाइल लेनी है या एच फाइल लेनी है, उसके अंदर से सॉफ्ट टिश्यू को हिट करना है, फिर इंसीजन देना है, फिर उसको चेक करना है कि वो जो होल है आपका अकॉर्डिंग टू बोन भी आ रहा है कि नहीं आ रहा है. बक्कोलिंगुअल पोजीशन चेक करनी है अपने को उसकी. मीजो डिस्टल तो प्रॉब्लम नहीं है, मीजो डिस्टल तो छेद ने बता दिया आपको, लेकिन बक्कोलिंगुअली हो सकता है छेद से जाओ और पता लगा आपकी ड्रिल जाई बक्कल कॉर्टेक्स पर गई है, फिर आपको थोड़ा उसको ऑस्टियोटॉमी को पैलेटली शिफ्ट करना पड़ेगा. So this is the rough guide. Now placed this is I think Ostem, 2 implants at the same time healing cap, and this is the laboratory work. And case number 3, tooth number 3, 5, 3, 6, 3, 7. This is a case of my visiting practice, so I don't have any kind of model or any kind of the prosthesis. So did 3 Ostem implants, prosthesis. Now I am giving the cemented prosthesis here, but still I am making the hole on the crown. So what I am doing, cemented screw retained. Cemented screw retained, I think it is the best one, because if you are going for a screw retained, you are using UCLA abutment. UCLA abutment में कास्टिंग होगी तो उसका जो इंटरनल हेक्स वाला पोर्शन है वो डिस्कलर्ड हो जाएगा, डिफॉर्म हो जाएगा, उसके ऊपर कास्टिंग के प्रोडक्ट जम जाएंगे, उसको साफ करोगे तो उसकी प्रिसीजन चली जाएगी. तो इंस्टेड ऑफ गोइंग फॉर दैट यू यूज द stock abutment, make a crown on it and make the hole over it. So you put your stock abutment into the mouth, cement your crown, then untighten your crown, remove it from the mouth, remove the excess cement and again tighten with the screw. So with doing this, you have a liberty of removing it whenever you want. And also you are having a very fine polished collar there. So this is the case number 4, tooth number 4-6, immediate. This I have included because this is a very good idea. Before extracting the molar, you cut it longitudinally up to the percussion, and through this percussion only you use your pilot drill. Because what happens in the molar region, आपने दांत तो निकाल लिया, अब बीच में आपके इंटररेटिकुलर बोन है, वहाँ पे आपको ड्रिल करना है. तो एक तरीका तो ये निकाला मैंने कि आप उसकी स्पीड कम कर लो हैंड पीस की, बिल्कुल 100 कर लो, 100-150, तो धीरे धीरे घूमेगी. तो आप उसको रख के पैडल को दबाओ तो आपका वो स्लिप नहीं होगा. बट अगर उसकी स्पीड फास्ट होती है तो अपने को परचेज पॉइंट ही नहीं मिलता, अपन रखते हैं वो इधर उधर भागता ही, हैंड पीस इधर उधर भागता है. तो उसमें क्या करना है अपने को, ये मेथड सही है. इसमें क्या है कि आपका मीडियल एंड डिस्टल पोर्शन ऑफ द जो टूथ है वो आपको सही जगह पे ड्रिल कराएगा. बिकॉज इट विल नॉट अलाउ द ड्रिल टू बी वाइब्रेट और चेंज द प्लेस. This is again tooth number 11. Here you can see in the X-ray very large this nasopalatine foramen, very large. So see the X-ray carefully, see the CBCT carefully, and before placing the implant सारे जो आपके दिमाग के खाने हैं उनको खोल के रखो और plan accordingly so you can avoid the complications. This is case number 3, tooth number 242526, direct sinus lift. Here you can see the osteotomy for the sinus lift on the lateral wall. Here you can see the membrane, and this is after placement of the graft, and this is the post-op X-ray. Thank you very much for patiently listening. मेरे ख्याल से आप लोग इसी चीज़ का इंतज़ार कर रहे थे इतनी देर से. Any questions, please? कि पहले इतना झिल गए हैं, और नहीं झिलना. ठीक है.
Now we will have 10 minutes tea break. After that we will start with our lecture 2.
झांसी ठीक रहा. हाँ
बेसिक तो सारा बता दिया, तो मेरे को सारा ग्राउंड वर्क तो हो गया.
पीछे कम आ रही थी क्या? ये यार एक्चुअल में वो होना चाहिए था हैंड माइक.
सबका बैग संभाल के
एक तुमने पहले पिक्चर देखी थी क्या बचपन में? वो
के किराए पे VCR देखा है ना?
तुमने आज तक कभी VCR सही चलते देखा? मैंने तो नहीं देखा। या तो कैसेट लगा लो, या VCR का लेंस खराब है, ऐसा इन प्रोग्रामों में
कहीं ना
आपको एक ना एक लफड़ा तो मिलेगा ही मिलेगा।
कहीं भी
या
चले
तो आवाज़ यहाँ आता करेगा, यहाँ वो
जाओ स्क्रीन में डिस्टर्ब ये स्पीकर ना विजिबिलिटी कम है।
दिक्कत मेरे को ये आई कि होटल वाले ने मेरे को जाते ही कहा कि 5,000 रुपये हो गए। ये फिर मैंने
क्यों दिया आपने?
मैंने कहा आपके 10,000 का बिल है।
मैंने उसको पेमेंट कर दिया था अभी देखो।
किसने? मेरे से जाते ले लिए। उस उल्लू के पट्टे को समझा कि यहाँ पर रुकेगा एक रात, कल जाएगा डाकू तोड़ियों में।
ये देखो अभी देखो मेल देखो आप, उसका मेल आया है कल देखो।
चलो आप आना हो देखो, आप मेरे लायक कोई सेवा तो बताना।
रिकॉर्ड ले लेना वो
और संकल्प को मंत्र से यार
मुझे रिकॉर्ड लेना है।
सामने फंड किस देगा वो मैंने उसका कार्ड से दिया था।
एक दे जाओ।
चलो नाइस मीटिंग। सबको बता देना यार मैंने कैसे मिला। मैंने 2012 में पास किया एंड आई वाज लकी एट दैट टाइम 12 में पास करके ये विज्ञान। ये बच्चे आए हैं हमारे GDC से, इनका एक फोटो ले लूँ मैं इनके साथ। ये वो ओरल सर्जरी में है ना तीनों, जी भी वहीं से है। नहीं जा रहा हूँ, आ जाओ आ जाओ। एक फोटो ले दो ना हमारे, आ जाओ यार। अरे छोड़ो बैंगलोर को यार। चाय पी लो निशान। कल पहुंच जाएंगे, मैसेज कर दो मेरे को कैसे चाहिए, मैसेज तो कर दो।
स्पीकर कौन है? अरे कहाँ गया अंकुश? चाय सर कदे सर का ध्यान देने में सर आगे
என்ன பண்ற
செட் பண்ணி வைக்கிறேன்.
ம்
செட் பண்ணி வைக்கிறேன்.
நட்டீந்தா
ஒரு
இந்தா
தர மாட்டாங்க ப்ராசஸ்ல கேட்டா
ஆமா
2 வருஷம் தாங்க அவளை கடுப்பை கதூர் கத்துறாங்க.
உங்களையா
ஆமா ஒரு கவர்மெண்ட் இன்ஃபார்ம் பண்ணுறது
அவங்க எடுத்துருந்தோம்ல தாண்டா நீ சைடு இதான் ஆயிடுச்சுன்னா
Start about
I hope everyone enjoyed their tea time. Now we are starting off with our lecture 2. So I would like to welcome Dr. Nishant Gupta, sir, on the stage to continue our lecture 2. He has done his graduation from RGUHS, Bangalore, and post-graduation in oral and maxillofacial surgery from the reputed KLES Institute of Dental Sciences, Belgaum. He has received training in various aspects of oral and maxillofacial surgery and implantology, including maxillofacial trauma, hard and soft tissues augmentation, indirect and direct sinus lift, GBR and piezo surgery, and soft tissue lasers in India and abroad. Currently, he is working as professor and head in the Department of Oral and Maxillofacial Surgery at Jaipur Dental College. He also conducts courses on implantology. So, sir, I welcome you here. A big round of applause, everyone.
Thank you. So good afternoon, everyone. Am I audible? Piche or you need the mic? So good afternoon. After a basic lecture on implantology, I think a lot of things Narendra Bansal sir has already covered, so I need not go into the basics, because single or two implants is a completely different ball game when we talk about implantology. And today my topic is only regarding the edentulous patients. So how many of you are postgraduates over here? So we have majority postgraduates. And how many from prosto? So I think prosto people would be more interested in terms of prosthetic part, because I'm not only covering all on four, because all on four is considered all on four or multiple fixed implantology, fixed options. I'll be covering the removable options as well. So initially First of all, I would like to thank Department of Oral and Maxillofacial Surgery of Nims, Dr. Amit Sharma sir, Vikram, and Principal sir, and Dr. Sunil Sharma sir, for giving me and inviting me over here for sharing my thoughts. And team iFix, Dr. Shahnawaz and Mr. Mohit are there from iFix for arranging all the things. So my first thing is never stop learning, because life never stops teaching. So first thing I would tell you all postgraduates is, even after your actual learning starts after you pass your post-graduation, because then you come to practice or academics, whatever you want to do. So this is the first step in your learning aspect. So today, after the basic implantology, we'll go into the edentulous, a slightly bigger thing. So these are my this is my center where I work, and obviously Jaipur Dental College where I'm teaching. So majority of work is done under local anesthesia, especially implants, even the full arch cases. But there is a part played by conscious sedation that now I use in a few of my adult patients as well. It's not only for children, but in patients, adult patients, wherein the patients are apprehensive, we also use conscious sedation for them. And this is about me. Apart from clinical work, I conduct courses as well. And cricket was, I have my captain of my Jaipur Dental team, Dr. Rajiv here. So we have played a lot of cricket, but of late I've moved to golf more than cricket. So it's not only about practice all the time, you have to have your extracurricular activities as well. So coming to the topic, edentulism. Prosper PGs know it better. With increasing life expectancy, one of the major problem of old age is edentulism. When we see the incidence of edentulism, 75 plus, and now 75 plus is not considered to be a very old age, and you have somewhere around 44% edentulism in those patients. So we get a lot of patients with completely edentulous arches or partially edentulous patients, but complete edentulism is increasing day by day, and the need for implants in those cases is also increasing because of the drawbacks of removable prosthesis. So consequences of bone loss is in edentulous patients, decreased support of decreased bone height, decreased bone width, the quality of bone is reduced, muscle attachments come closer to the crest, thinning of mucosa, loss of basal bone, paresthesia from descent mandibular neovascular canal. So all these are basically the theoretical part that you know consequences in edentulous patients. So what are the treatment options? One is complete dentures or implant supported prosthesis. So in implant supported prosthesis, there are a lot of things that are there apart from the fixed prosthesis. What are the drawbacks of removable prosthesis? Bite force is decreased, all of us know. Masticatory efficiency is decreased because the patient wants to chew. आज की date में, why are now till date our parents, they are not used to eating out, but now generation wants to eat out and have everything. So as these things are increasing, अगर आप उनको बोलोगे कि just एक दाल चावल खाओ और खुश रहो, तो वो नहीं होता. So even patients are not willing to use complete dentures. They want the fixed treatment on day one. So that is important, but not every patient is a candidate for a fixed. So that is what you need to know. Pros of implant retained prosthesis, they maintain bone. The first important thing is if you put implants, the amount of bone loss, the rate of bone loss reduces as well. Restore and maintain occlusal vertical dimension, facial aesthetics, very important. Nowadays I see a lot of dentists doing facial aesthetics. है कि नहीं? आप लोगों के कितने बैचमेंट्स कर रहे हैं? कई लोग हैं, those who are going into facial aesthetics. So there is a huge demand of facial aesthetics, and dental component is very important with that. Improves phonetics, improved occlusion. Obviously, if you give them a fixed option, the chance of occlusion is better. Increased prosthetic success. reduces size of prosthesis. The most important thing in fixed prosthesis against the removable complete dentures is the elimination of palate and flanges, because the patients are not able to speak very clearly with that, and a lot of patients have those issues with the full complete dentures. And it's more permanent replacement and improves psychological health. So what are the options with the implant retained prosthesis? So with implant retained prosthesis, we have the removable options, the overdentures, the fixed, either 6 implants, 8 implants, if you have sufficient bone. If you do not have sufficient bone, then you can go in for all-on-4 or zygomatic or pterygoid implants, and obviously basal implants is another option. So just an overview, what are these? Because bolna आसान है, when you have not seen those cases, it's very difficult. So this is a ball attachment. There you can see a ball over the implant. Sir has already told there are different kinds of cement retained direct abutments, castable abutments. So this is an overdenture ball abutment that goes on top of the implant, and the female part is the silicone cap and metal housing is on the denture. So it's connected to the implant through the ball abutment. The second option is a locator abutment. It's a reverse of ball. So the ball part goes in. It's like the ball is coming up on a ball abutment. The locator abutment has a depression or a concavity inside the abutment. So it's the reverse, the other way around. So what happens with this is you get a very low profile abutment. So ball part, you need more clearance. The locator needs a very less clearance. In a few cases where you have less amount of bone, or in cases where you cannot go in for fixed prosthesis because of your positioning of the bone or the need for vertical replacement, you can get this kind of bar attachment, wherein 2 or 3 implants are connected with a bar and a silicone sleeve is inside the prosthesis, and it is again an overdenture. It's not a permanently fixed thing, but the bar is inside the patient's mouth, that is fixed, and the denture can be removed. So this increases the stability and retention of the prosthesis. Then we go in for fixed options. If you have sufficient amount of bone, then you can place 6 implants on the maxilla, 6 in the mandible, give the whole the patient a fixed prosthesis. If you do not have sufficient amount of bone in the posterior regions or the body region of the mandible, then you can go in for all-on-4. And if you do not have sufficient amount of bone in the maxilla at all, then you can go in with the zygomatic or the pterygoid implants. And if you want to give the patient immediate loading, and there is an option and the bone is not sufficient, then you have the option of basal implants as well. So the bicortical implants. Today, I would not be going into details about bicortical. That's a completely different subject because that science is slightly different than the conventional implants. We'll be talking about the conventional implants. So already treatment planning as discussed by Narendra sir. The basic treatment planning remains the same. The medical history, the dental history, the clinical examination, everything is the same. The basic treatment planning, the history taking for an implant, for a full mouth implant and a basic single implant is the same. You should not just overlook things. It's not the patient is coming to you क्योंकि अपने को क्या लगता है सबसे पहली चीज इम्प्लांट करना क्यों चाहते हैं सब लोग? इसने मनी बोला है वहाँ पे. सबसे पहली चीज होती है when in a private practice we think that this will give us more money, but the problem is if you do not take a history properly. एक बार patient क्या आता है जब एक patient आता है edentulous patient, the patient is ready for implants. आपको क्या लगता है यार आज 3 लाख रुपए 4 लाख रुपए कमाएंगे? That is the wrong concept. First the patient comes in, he has to be treated like diagnosed as a patient needing a solution. It's not the solution, the diagnosis comes first and then the solution. It's not the other way around. So if you go in for the solution first, you at times err at the diagnosis. And today, though I won't be covering complications of it, I have had a lot of complications. I've seen a lot of complications. A few complications, I'll show you a case, I'll show you what had happened. But that needs to be taken care because एक इम्प्लांट जब करते हो आप, so इम्प्लांट का पेशेंट की आपसे शादी हो जाती है. अब दो ही तरीके से शादी टूटती है, या तो आप उसको खींचते रहो और या फिर डिवोर्स होएगा. डिवोर्स में यू हैव टू गिव कंपनसेशन. तो उसके अंदर कंपनसेशन कहाँ से आएगा? आइदर द पेशेंट गोज टू कोर्ट एंड टेक्स यू टू कोर्ट एंड योर पीस ऑफ माइंड इज गॉन, और नहीं तो पेशेंट अगर थोड़ा सा एडजस्टिंग है तो आप उसको रोज बुलाओगे, कुछ ना कुछ करोगे, कुछ आप उसको बोलोगे एंड देन नेक्स्ट टाइम के लिए वेट करोगे कि कब उसका फोन आएगा, फिर आपको स्ट्रेस चालू होगा कि यार अब क्या हुआ. So those things should not be there. That is why this is very important. So what and radiographs again, IOPA, OPG, Dentascan or CBCT. Now Dentascan is gone, CBCT is the gold standard. CBCT is a must for every full mouth case. You cannot avoid doing a CBCT if you are doing a complete implant prosthesis. Prosthetic driven implantology, as Sir had told, in single implant cases, you need to take impression, design the cast, take the cast, design a tooth, place a tooth, see where exactly is the position. So ideally that should be done on implant, full mouth implant. That is more important because that will tell you what kind of patient it is. If the patient is a good candidate for a removable implant supported prosthesis, or he is a good candidate for a fixed prosthesis. So the first thing that implant in full mouth cases that needs to be done is making of a complete denture. तभी मैंने prosthetics के लिए पूछा था prosto वालों के लिए, क्योंकि implantology at the end of the day is a prosthetic branch with a surgical component. It's not a surgical branch with a prosthetic component. मैं oral surgeon हूँ, but that I realized after a lot of failures with implants because शुरू में what we were taught was कि आज ये डेंचुलर स्पेस दिख रही है, इम्प्लांट डालो, प्रोस्थेटिक तो कैसे भी लग जाएगा. बट देन व्हेन यू गेट टू द प्रोस्थेटिक स्टेज, इट बिकम्स वेरी डिफिकल्ट टू प्लेस अ प्रोस्थेसिस because as Naren sir had told that patient is not coming for you for implants. He wants a solution for his edentulous thing. So he wants a tooth. उसको कोई फर्क नहीं पड़ता आप इम्प्लांट लगाओ चाहे नहीं लगाओ, उसको दांत चाहिए, उसको खाना खाना है, उसको स्माइल अच्छी चाहिए. Those are the basic criteria. So first thing, mouth opening, as sir had told, in edentulous cases it's more important because you have to take impressions of the whole arch. It's not a single tooth that we are doing anterior में. So the mouth opening, the more is the mouth opening, the merrier. अगर इस तरह की mouth opening है तो कोई दिक्कत ही नहीं है, फिर तो कहाँ pterygoid 8 में भी implant डालोगे तो कोई problem नहीं है. But these kind of patients where this patient had undergone cancer therapy for tongue cancer, the patient had come to me with this kind of mouth opening. So first thing I had done was to refer him for a mouth opening surgery. Either oral surgeons can do it, or if the patient at times is more comfortable with the cancer surgeon he has gone to, so then you can refer him for mouth opening surgery. So that can be done with maybe nasolabial flaps or free flaps or whatever the patient wants. But for mouth opening is very important, especially even in case the patient comes to you at that time he might be okay. But cancer patients, you should remember, with time the mouth opening reduces. So आपने implant डाल दिया, 3 महीने बाद आपको prosthetic करने गए, पता चला mouth opening कम हो गई, implant तो अंदर पड़ा है, अपन prosthesis नहीं लगा सकते. So that has to be planned. So that is why history is very important. Why these things are happening. Then lip position. So which candidate would you say, this one or this one is good for a full mouth implant case? First one or the second one? Why? If this kind of a patient comes, or a patient with a gummy smile comes, which is a better patient for a implant case? क्यों? बोन तो इसकी ज़्यादा होगी ना, है कि नहीं? नहीं, bite. Assume this. or this. So which patient would have good amount of bone? जिसके वर्टिकल ज़्यादा है, बल्क ज़्यादा है, या जिसके लिप शो मतलब मैक्सिला दिख ही नहीं रहा. सेकंड वाला would have good amount of bone. So वो तो implant patient अच्छा होना चाहिए. This because aesthetics. Because what happens is there is a zone of transition. When you give a prosthesis, जैसे हम complete denture देते हैं, so you have a flange. You go up till the buccal fold. So there you can cover that zone. Now, if this kind of a patient comes to you and there is some amount of bone seen, and if you plan a prosthesis here, the patient smile, as soon as the patient smiles, there would be a zone of transition from the prosthesis to the normal mucosa. So that should be above the lip line. Because we do not want, when the patient smiles, you can replace the soft tissue with pink porcelain. But you cannot hide that zone in case it is seen on smiling. So the first and the most important thing is mouth opening. Then you have to ask the patient to smile properly and check for his smile line. If there is some amount of bone seen, then you have to reduce that bone, take it up, and then do implants. So your prosthetic plan changes. And cheek position. वैसा अगर cheek आएंगे तो फिर it's better you do not do implants, because or you should have 2 or 3 assistants to handle the cheek and then do implants. So this is very important, especially when you are doing maxillary posteriors, mandibular posteriors. If patient comes with a cheek like this, because this patient I had done and I had a bad time managing this, because 2 assistant मेरे चाहिए थे, एक cheek को retract कर रहा है, एक tongue को retract कर रहा है, एक suction पकड़ रहा है. तो ऐसे 2 assistant मेरे लगे थे जब मैंने ये patient करा था. So this thing also you have to consider when you are doing implant. Then tongue. If the patient is having macroglossia or tongue thrust, then your loading on implants would be too high. If you close, especially in a patient with tongue thrust, I had seen the patient had got his implants done, a full mouth rehab done. The patient had come to me with completely fractured upper prosthesis. That was a natural prosthesis, and the only thing was he was having tongue thrust, sleep apnea, everything. So his tongue was constantly putting pressure on the prosthesis. So that needs to be taken care, because if that is the case, you have to slightly give an open bite in the prosthetics. Because if you do not give tongue space to the tongue is a very strong muscle, so it will fracture whatever is there. So you will end up in failures and complications with implants. Though initially it will look very good. आपने सब कर दिया, 3 महीने बाद patient आया, सारा prosthesis loose है. If you do a cement retained, it might fracture. So we do not want those things happening. Then teeth, already we have spoken about the intra-arch space, the implant distance. The minimum is 3 mm between implants and 1.5 mm between the tooth and an implant. Gingiva. If you have a very thick gingival type, your life becomes easy in terms of implants, because at times your the grafting part that we are, even I'm not too into grafting, but if the patient has thin gingival type, then you might need to graft. If the patient has thick gingival type, you can work without grafting as well. So that needs to be taken care of. Usually in old age females, there is thin gingival type. So in those cases, you have to be very careful about your implant positioning. Then material. कितने लोगों ने सुना है कि क्या-क्या materials available है अपने पास? One is porcelain, one is a hybrid denture that you say, or an over denture. So इसका criteria क्या है? How do we decide कि भाई ऐसा नहीं होता कि patient afford कर सकता है तो उसको over denture दे सकते हैं, उसको afford कर सकता है तो all on 4 दे सकते हैं, या 1 full arch दे सकते हैं, afford नहीं कर सकता उसको over denture दे सकते हैं. हाँ, एक criteria है ये, but in terms of material, what would you choose? So if there is no space between the cervical portion of the duplicate denture teeth and the edentulous ridge, so that gives a tooth only defect. Then you have to go in for a metal ceramic one, because a hybrid would need more amount of space, because hybrid means metal and over which we put acrylic teeth. So acrylic would need more amount of space. So this is a metal ceramic prosthesis, wherein there is moderate to significant space between the cervical portion and duplicate denture teeth. There is a composite defect. Either you can go in for a hybrid prosthesis or a removable prosthesis. So that needs that at times of denture fabrication. That will tell you. So we should have a denture fabricated for these kind of patients. Diagnostic cast, dentures and mock-ups should be done to tell to see and evaluate what kind of prosthesis is needed. Radiographic evaluation, sir has already mentioned about CBCT scans. So that is the gold standard for planning any dentulous case, because you want to see the bone in 3 dimension. It's not only a 2-dimensional picture. OPG can give you a suggestion regarding the amount of bone, but at times it's overlapping and you do not have sufficient amount of bone in the sinus region. And if you plan an implant, and I've retrieved implants from the sinus. While placement, it went into the sinus because the dentist thought that sufficient amount of bone is there, but it was not there. So then the retrieval of implants have to take place. Surgical stents, as sir had told, we can design a surgical stent. It's not a guide. It's just a stent to guide us. Okay, this would be the implant position, but then you need to open up the flap, check the bone buccolingually, and then place your final osteotomy accordingly. So this just gives a guide. Okay, this would be the final position, and this can be made. जैसे sir ने बताया कि we can place a tooth there and make a night guard kind of material can be used, and a surgical stent can be made. When we talk about surgical guide, so surgical guide is planned completely virtually first, in which we put in all the diagnostic models. Nowadays with the intraoral scanners, we can directly acquire the data and put it into the computer, feed in the CBCT, and then plan everything on the computer. If everything is fine, so in this you are sure that you are in the bone. So the guide is fabricated. Nowadays we 3D print the guide and do a flapless surgery if you have sufficient amount of bone. So resorption of maxilla and mandible. Bone quality is important. D1, D2, D3, D4 bone. Which would be the best bone to place an implant? D2 or D3? Because D1 is too much of cortical, so blood supply is less, and D4 is too soft. Then comes the bone quantity that you need to see. A is the most alveolar ridge is present. Usually, hardly we get those kind of bone in case of edentulous patients. The most common is B or C category that we get.
जिनके सर A होती है ना उनके पास पैसे नहीं होते।
हाँ वो भी है। यही प्रॉब्लम है। Inversely bone amount of bone is inversely proportional to money. So atrophy of maxilla, these two bones are very good. You need not do anything, directly go in with an implant. But mostly what you will get is these 3 kind of bones. So there you have to think about what needs to be done. Similarly with mandible. Now this is a very important thing. How do you assess कि you want to go in for all on 4 or all on 6 or 8 or zygomatic implants? So these are the 3 zones that you need to know. First is the premaxillary zone, second is the bicuspid zone, and third is the molar zone. So yellow line is the premaxilla, white is bicuspid, and blue is molar. So if you have sufficient amount of bone in zone 1, 2 and 3, then you can go with normal implants, maybe 6 or 8 implants, whatever you want, and give the prosthesis to the patient. If you have zone 1 or 2, zone 1 and 2, then you have to go in for all on 4, because you have sufficient amount of bone in the premolar till the premolar region. So you can put the implants then and give some amount of cantilever, that is acceptable. If you have only in zone 1, then you can go in for zygomatic implants or pterygoid implants, along with some implants if you have sufficient amount of bone anteriorly. Otherwise, if you do not have bone anywhere, then you have to go in for extramaxillary implant placement, that is in zygomatic bone. So quad zygomas have to be done. So in edentulous mandible, if you have sufficient amount of bone everywhere, then you can go ahead, put 6 to 8 implants again. Mostly mandible, because it's a thick bone, you will get bone in the anterior region in most of the cases. So the intermental foramen, the parasymphysis region, in those cases you can go in for all on 4 if it's possible. The burning question in today's time is immediate loading. हर जना चाहता है आज ही इम्प्लांट डालो, कल मेरे को दांत मिल जाए, क्योंकि at the end of the day patient is coming for teeth, not the implants. So in conventional implantology, the stability of dental implants over time is shown in this graph. As soon as there is one is the mechanical stability and biological stability. Mechanical stability depends on the bone, one. If you have D2 bone, then you have good mechanical stability. आप सिंपल सा एग्जांपल दूं, अगर आपको कील लगानी है दीवार पे, तो एक पत्थर के अंदर अगर अपन लगाएंगे या एक मिट्टी की दीवार है उस पर लगाएंगे तो किस पे स्टेबिलिटी ज़्यादा होगी? सो अगर D1 D2 बोन है, सो यू गेट गुड स्टेबिलिटी. सेकेंड थिंग इज डिजाइन ऑफ द इम्प्लांट. इफ यू हैव एक्टिव इम्प्लांट, aggressive threads, those would be more stable than your passive implants. So if in case you are going in for immediate loading, so you have to consider the amount of bone, the type of bone, and the type of implant as well. So with iFix, they have 3 options with them. One is a passive implant, one is a very active implant. So if you are going in for immediate loading, then you have to go in for an active implant. So जैसे iPhone और iPhone Pro है, वैसे iFix में उनका iFix का और iFix Pro है. So that you need to decide about, because obviously with the technology, costs go up. So you have to see which is good for your patient. So not every patient is a good candidate for immediate loading. ऐसा नहीं है patient आते ही अपन बोलेंगे सीधे immediate loading में डाल रहे हैं. So initially the mechanical stability is 100%. So when you place the implant, there is no biological bonding. Osseointegration नहीं होता. It will take time because it does not depend on the implant. It depends on the bone. So initially it's mechanical stability, but with time the mechanical stability comes down and biological stability goes up. So we have to, if we are doing something, it has to be initially, and then once the biological stability is there, then it's in the long term that is successful. The second concept in all on 4, especially when you are giving cantilevers, is the AP spread. So ये 2-3 concepts हैं जो आपको full mouth में ध्यान रखना है. In this, the AP spread means this is the anterior-most implant to the line joining the posterior-most 2 implants. So this is the AP spread. The more the AP spread, the more the cantilever. आज मेरे पास अगर इतना समय इसके ऊपर anteriorly मैंने इस पे रखा हुआ है and मैं इस पे पीछे force लगा रहा हूँ, तो इस पे force ज़्यादा आएगा यहाँ पे. If I have more amount of spread here, so then force is reduced. So आगे वाले implant में force कम पड़ेगा. So though more amount of AP spread is there, better and longer can be the cantilever. So that is the concept. So these are the 3 kind of arches. In this, U-shaped arch is the worst for cantilevers because the AP spread is reduced. आप उसमें ज़्यादा implant भी डालोगे, but अगर AP spread नहीं है, so the cantilevers would be damaging for the posterior most implant. The V-shaped arches are the best because इसमें AP spread would be better. Okay, so these are 3 concepts you need to remember in cases of full arches, especially all on 4s. Theoretical part खत्म हो रहा है. So implant maintenance is very important, especially in cases even with single implants or multiple implants. You have to ask the patient to maintain it properly, because the problem is with full arches the patient thinks कि हमारा brush करा तो हमारा बहुत है, but what happens is the junction. The undersurface of the prosthesis would be lined with your plaque and calculus and will harbor bacteria and would result in peri-implant mucositis, peri-implantitis, and finally implant failure. So we do not want that happening. So for that, you can use water flossers or interdental brushes to clean the undersurface of the implants. अब थोड़ा सा इंटरेस्टिंग पार्ट आ जाएगा सबको. पेशेंट देखने हैं थ्योरी के बाद. तो अब आप लोग जो सो रहे हैं वो उठ सकते हैं, तो मुझे दिख रहा है कि काफ़ी लोग सो रहे हैं, अब नींद आ रही है सबको दोपहर में. So now we are going with patients. I'll show you a few patients wherein different scenarios are there and how I have managed them. So this is an overdenture patient wherein we have placed, इसमें थोड़ा सा clarity का issue है. We have placed two implants with the locator attachments, and the locator attachment housing is within the denture, and these are placed and they just act like a titch button. So it just goes in and snaps in. At times the patients cannot take it out. So you have different color attachments, all silicone rings. These are yellow silicone rings. You have transparent, you have black, pink, depending on the elasticity. So if you can change those depending on the patient's requirement. Then all on 4. So a patient here, we have, this is the clinical condition, huge amount of bone loss, periodontally compromised teeth. The patient wanted teeth for his cosmetics, plus obviously mastication. So I had gone in with 4 implants. These are the multi-units, sir. I told multi-units because these are angulated implants in place. So with multi-units, we make them parallel, because if they are at an angle, the stresses would be on certain implants, and that might lead to failure. So the more the parallel the implants, the better, especially the prosthesis. In this case, I had done immediate temporization using the existing denture. Initially, I had shown you, first we extracted the teeth, then made a denture, then we placed the implants, and then we temporized the existing dentures and gave the patient a fixed prosthesis. So these are the 4 implants that have been placed with the temporary cylinders. Here you can see they are engaging the cortical bone, and these are the lower implants as well. So they are at an angle, but with the multi-unit abutments, we have made them parallel. So this is the prosthesis. This is the final prosthesis. After 6 months, as you can see here, there is a deposition of plaque and calculus below. The 6 months follow-up, X-ray looks fine, the implant positions are good. 3-year follow-ups. But the X-ray, 3-year follow-up X-ray was okay, but you can see the intraoral condition. Now what happens after 3 years is, because of the wear and tear, the teeth go wear out. So we have a few teeth that have come out. The patient had a hybrid prosthesis. Though the implant and the fitting looks fine on the X-ray, but clinically this does not look good. Finally patient X-ray नहीं देख रहा, patient को दांत दिख रहे हैं. So he is not happy कि डॉक्टर साहब इसमें क्या करना है, ये तो दांत ऐसे हो रखे हैं मेरे. So in this, with a screw retained prosthesis, it becomes very easy to replace this, because a screw retained prosthesis with a hybrid, you just need to change the acrylized portion. आपका fitting वही रहेगी, because metal framework perfect है, your implants are in good position, so everything is good. So now what we do is, we just make impressions using the existing denture, the prosthesis. So I'll show you another case in detail. This is impression copings are placed through the existing denture and we pick up the impression. So we do not need to go in with पूरा आपका impression और सारी चीजें, jaw relation, everything is done already. So we need not do everything again. And this is in the second sitting. The same patient, implants are the same, the metal framework is the same. We have just changed the acrylized portion. So in 2 sittings, you can change the whole prosthesis. And this is the 6-year follow-up of the same patient. So this was one of my initial all-in-4 cases 7-8 years back. Everything looks fine, the implants are fine, prosthesis is okay, so everything is good. So the most important thing in all screw retained is the maintenance of the prosthesis. So this is the patient. Now another case wherein patient already had a few implants. Patient had a few implants like this. He had 4 implants on maxilla. Rest of the teeth looked periodontally very compromised, and they became grade 3 mobile. Then the patient wanted, I had given him an option for the lower one as well, but lower one he was okay कि भाई ये तो चलने दो आप, अब से ऊपर का दांत चेंज कर दो. उसका भी main reason था because the central had come out, because the smile had gone. Now in this case what I did was we maintained the 4 implants. We did not add on too many implants. The 4 implants were used that were there. 2 implants were added. So we have 6 implants over here. 6 implants over here. And the prosthesis was made. So in this case we went in for PFM prosthesis. The problem with this thing was the patient was not willing for multi-units. He was not ready to pay that much. So the challenge with me was a few implants anteriorly. If you see, these implants are buccally proclined. So if we try to give a screw retained prosthesis, then you will have a hole on the front surface, and that does not look good. However aesthetic work you can do, there would be a transition zone between a composite and porcelain. So with time that will stain, the composite will stain and it will show. So the option there is either you can go in for a cement retained, the whole thing, you can place the stock abutments, do a cement retained prosthesis, or this is what is called as a polo molo kind of a prosthesis, in which I did a screw retained prosthesis, but 3 areas where the hole was coming buccally, we made separate crowns for it. So here you can see. So now this is the final thing. So these 3 crowns are separate. These 1, 2 and 3. So though when you need to take it out, you just need to remove the 3 crowns, open up the whole prosthesis and it will be out. So that makes it easier. Otherwise with the cement retained prosthesis you have to cut the whole thing out, and then to maintain it maybe after a few years it becomes difficult. So this is the final picture of the patient, an extraordinary. And this is, we have just added 2 implants. So when the patient comes to you कि डॉक्टर साहब कई बार क्वेश्चन होता है कि आज 2-3 इम्प्लांट डलवा रहा हूँ, कल को मेरे बाकी के निकलेंगे तो क्या होगा? So then you can say कि भाई implants we can use, but the prosthesis would change. So the cost of the patient would not, जो implant का patient को एक बार लगता है कि भाई I'm spending 30-50,000 rupees on a single implant at times. What will happen to that? So you can say कि if you are spending that much, the implants we can use later on if needed, at after you lose your rest of the teeth, and we'll make a new prosthesis, so to give you a new smile. And this was 8/20/20. This was after 3 months. So all on 4 with immediate final loading. A few cases I do in case I feel the bone is fine, everything is fine, then we do immediate final loading as well. You can see here, again periodontally compromised teeth, immediate implant placement in all on 4. This is maxillary, and then what I try to do is put the multi-unit abutments at the same time, so that in case you need slight angulation changes in multi-units, you can do at the time of surgery as well. So that makes your life easy in case you are going in for an immediate loading. So these are the 4 implants on maxilla, 4 in the mandible. Sir had told to splint multiple implants with maybe composite or ligature wire or floss. One more thing is there that you can use a pattern resin. So this resin, also people would know better. मैंने भी oral surgery में मुझे भी नहीं पता था. तो जब implant करने चालू करे तब problems पता लगती हैं, तब अपन उसको improvise करते हैं. So the pattern resin, it sets very fast and the shrinkage is less and the splinting is better. So with the impression if you take, then the problem is if you take the impression, if you have 4 implants and your screw moves by 2 degrees, at the end of the day there is a huge discrepancy that happens and then your prosthesis would not see it. So with the splinting your movement is reduced. With the digital scans these things are eliminated, but जब तक digital नहीं होता तब तक अपने को analog style में करना पड़ेगा. Complete digital prosthesis solutions नहीं आते तब तक. So this is one thing that you can use. Then bite jaw relations, I've started using face bow transfers 4-5 साल पहले. जब प्रॉब्लम आने लगती हैं उसके बाद ही अपन सोचते हैं. That is why I say कि prosthetic branch है, it's not a surgical branch. Again, this is PFM prosthesis because the interocclusal distance was not too much. This is a completely screw retained PFM. So this is the final prosthesis. This is the final X-ray. Another with tuberopterygoid implants. Again, the patient has poor oral hygiene, so these kind of patients usually do not have bone. So you can see here, there is no bone in the molar region and maxilla. The mandible also, the amount of bone is less behind the mental foramen. So here I had gone in for 6 implants involving 2 tuberopterygoid. This we had done immediate temporary loading. That is why I did not involve the tuberopterygoid implants. So this maxilla and this mandible with multi-unit abutments, we got into relatively straight line. Here you can see all the 6 implants in, 4 in the premaxillary and the parasympathetic region, 2 at the back. I at times leave the patient for say 7 days or 10 days, let the healing happen and then go ahead with the prosthesis part. So this is after 7 days, we make all the impressions, splinting of the impression copings, and this is the temporary that we are given. And temporary is without the framework. It's not, there is no metal framework below. So this is a temporary. Temporary may do not give cantilevers. The most important thing is do not give cantilevers if you are giving temporaries, because you cannot control the posterior bite. क्योंकि पेशेंट का क्या है, उसको दांत मिल गए, हिंदुस्तानी पेशेंट नहीं रुकता. तो 1-2 पेशेंट मेरे पास आए हैं, स्पेशली जयपुर वाले जितने अगर है यहाँ पर, तो मैंने कहा सुपारी बंद करो, तो बोलते हैं सर दांत लगाई सुपारी खाने के लिए रहे हैं, आप बोलते हो तो सुपारी बंद करो. So you cannot manage those people. So it's better you be more cautious than them, because at the end of the day if something fails तो वो आपके ऊपर ही आएगा. So this is after 1 year. The patient did not turn up क्योंकि कुछ ये एक नुकसान है अच्छे टेम्पररी बनाने का भी. Patient was happy कि मेरे टेम्पररी से काम चल रहा है, तो patient did not turn up for 1 year. So this was after 1 year. I had taken out the prosthesis, and you can see over here what has happened on the under surface of the prosthesis. This is why I was telling you the maintenance is very important, because I was lucky that peri-implantitis did not happen, but at times it might result in peri-implantitis as well. In this what I did was I used the same prosthesis. So what I was telling you, these are the pins of open tray copings. So I used the same prosthesis to pick up the impression. So I need not do the whole thing वो अपन ने जो cold pattern resin से करा कि we had to splint up the open tray copings. We skip that step, go ahead with the next one, and we also have a bite here. Already we have done the hard work in the first time. Why unnecessarily do the same thing again? So we already have a good bite, we just replicate it. Already bite अपने पास है, so we have just made the impressions. So these are the impressions there. Send it to the lab, they pour it, already the prosthesis is there inside the impressions. So they take it out, put it onto the cast and take a bite. So articulation भी हो गया आपका impression भी हो गया, सारा एक ही sitting में हो गया. So you save on 2 sittings of the patient and yourself. This is the metal trial. Obviously, whenever you are doing a framework, metal trial is a must. This is the trial with teeth, and this is the finished prosthesis. So what you have to do is polished under surface. That is very important so that there is less accumulation of food there. And this is the final prosthesis that we have given the patient. There you can see the final X-ray of the patient with 6 implants on the maxilla and 4 on the mandible. So from here to here. So that is what is achievable. But planning and execution are the most important thing. This is the last case. अब मैं और बोर्ड नहीं करूँगा क्योंकि अब सबको भूख लग रही होगी. It's almost 1:30. This case, I'm showing you another complicated case. Already the patient had a complete upper prosthesis, a full arch prosthesis. The lower one, the patient had a partial one. So this was the condition of the patient when he came to me. So they had placed around 7 implants for the maxilla, 3 for the mandible. Here you can see this implant is failing. This implant was also failing, but जब मैंने prosthesis हटाया तब मुझे पता लगा. Actually initially the patient had these teeth as well, but with time these teeth fell out and the patient was chewing only from one side. So that is why here you can see this side is completely worn out and he has teeth over here. So that is important because you need to follow up these kind of patients, otherwise implant failures would happen. So in this what I did was I added a few implants. Here you can see the upper implants were the same. I just took out the prosthesis. Lower we took out 1 implant, added 3 implants, made it 5. The upper one I followed the same guidelines and picked up the impression along with the prosthesis, but here the bite was not possible, so we need to do the whole bite part again. But because it's already splinted, so we need not do the splinting again. The lower one we did the same way, splinting with the pattern resin. The lower impression, bite, everything is done. Trial, and we are finished with the new prosthesis. So here everything is there. 1 implant had failed here, so I had just removed the implant. I did not remove the tooth, reduce the framework from that side, and you have a happy patient again. So you need to improvise at times to think out of the box and reduce the cost to the patient. This patient was 83-year-old. This is an 83-year-old patient, so I do not want to do too many surgeries to him already. Now एक last part है छोटा सा about guided surgery. So ये कोई cricket के जो अभी World Cup चल रहा है. So what is the difference between these two West Indies teams? They have not qualified for the World Cup this year. जो 75 में they were the champions. And what is the reason for that? And they have not adapted to the latest concept. अभी भी वो उसी fast bowling करनी है तो fast bowling है और they have not adapted to the whole thing. So in dentistry, freehand surgery is a part of it. The second thing that is going to come is digital. So digitally nobody wants to just sit there, do a surgery. ठीक है, surgeons जो करते हैं वो जो oral surgery वाले हैं उनको surgery अच्छी लगती है तो सुबह से शाम बैठ के आप implant डाल रहे हो. But at the end of the day, you need peace of mind, you need proper planning, everything. So if you can do it virtually, then why unnecessarily adrenaline rush के लिए आप वहाँ पे सिर्फ implant डाल रहे हैं? So with digital dentistry, that is different. So guided surgery or for overdenture. Now what do you think about this case? इसमें क्या implant डाल सकते हैं? So you can see the mandible here. What is the condition of this area? मैंडिबल में इम्प्लांट डालेंगे तो कैसे डालेंगे इसके अंदर? तो दिस इज वेरी थिन. इवन अ फ्री हैंड इज नॉट पॉसिबल बिकॉज यू डू नॉट नो वेयर यू विल गो. यहाँ पे अगर मेंटल नर्व है उसके ऊपर ही डाल दिया तो पैरेस्थीसिया हो गया, काम खत्म. सो फॉर दिस यू कैन प्लान गाइडेड सर्जरीज. So guided surgeries, as I had already told, everything is fed onto the computer. You plan on guided softwares, and it tells you exactly where the implants are going to be placed. In case sufficient bone is there, you can go flapless. The guide is 3D printed like this. You place it. Different guided kits are there. This is the Ostem one. I use the Zimmer one, Dio one. A lot of companies are there. iFix are going to come up very soon with that as well. So this is the guide in place. Implant, osteotomy, everything is done through the guide. So you do not take out the guide again and check. And this is immediate post-op. This is the same day of surgery. So here you can see there is no bleeding, nothing, and healing caps are placed. This is the same day. So there is no bleeding. The patient had kidney issues, the patient had heart issues, the patient had diabetes, everything. So I did not even make a cut. The stability was good. This is the radio frequency analysis unit in which we see the bone implant contact. It was around 85, so that was very good. And these are the implants. So I think freehand I would not have been able to place this implant over here because there is a big ditch just posterior to it. So this is only possible with guided surgery. And then because the patient already was a denture wearer, so we just put locator attachments and give him a overdenture. So total surgery time कितना होगा इसमें? कितना होगा? 15 मिनट. अगर मैं उसको फ्लैप ओपन करता, सारा करता, मेरे को फ्लैप ओपन करने में सूचनिंग में ही आधा पौना घंटा लगता. So guided full jaw implants with same day immediate temporization, that is also possible. You can plan even the prosthesis beforehand. So this is the condition of the patient. The patient did not want the upper prosthesis, she just wanted the lower one. This side done with Dio. Dr. Shanawaz is there from iFix. He was the person with me at that time. He was in Dio, so he was the person with me for this case. So everything is planned beforehand. All the implants, everything, even the prosthesis, everything is sent to you beforehand. Everything is planned beforehand. This is the guide that is there. You place it in the mouth, did the extractions, did the implants. This is the immediate post-op. Prosthesis was made. These customized abutment were milled before. The only problem I had was I did not find too much good stability for the lower two implants, anterior two implants, so I did not load them initially, but back 4 implants were good. So we placed the abutments on the posterior 2 on this side and on this side, and these 2 were embedded. Gave the patient a temporary prosthesis. That was pre-planned. Everything was pre-planned. There was no impression, nothing. Initially we had taken impressions and scans, and then we had sent the whole thing to the lab. Then these are the impressions again, the abutments that we had made initially. Here we did a screw cement retained prosthesis, wherein I left the holes on top. There you can see holes on the inside. They are all fixed to the abutments are fixed to the implants, though they are customized abutments. They are not stock abutments, but they are fixed, and on top of it we have cemented the whole prosthesis. So this is the intraoral picture, and this is the final. So take home messages is the planning is most important in especially full mouth cases, or even any implant case that you do for a long term success. Go for maximum number of implants possible. If you have sufficient amount of space, go in for 6 or 8 implants. Graftless procedures prefer to reduce healing time because you have options of multi-unit, so you can do graftless procedures as well. Screw retained prosthesis for multiple implant cases, I prefer that because maintenance is easy. Regular follow-ups are a must because I've shown you cases where in regular follow-up, because of patient not regularly following up, they have had a few implants failures, and keep learning and keep working. So my take-home message is learn continually. There is always one more thing to learn. In dentistry, every day a new thing comes up. So जब मैंने start करी थी, I did not know even about impression materials. Then with implants, you need to know a lot of things. Now we are going digital, so digital में you have daily we have challenges, and we are trying to sort them out. So maybe digital dentistry after 1 year it would be more. So ये conventional impression making वगैरह सब खत्म हो जाएगा. So with that, I'll finish off my talk, and I would invite you all for the Jaipur Dental Show that is happening on the 2nd and 3rd December in Jaipur. So that is Rajasthan International Center at Chalana. There we are having, this is the FDI IDA CD program as well. So we are having 2 days of intensive lectures. A lot of international speakers are coming, 4 or 5 of international speakers are there, and then Indian speakers are there. From TMJ, Sankalp Mittal sir is there from Jaipur. He'll be talking about implants. Bhagwan Das Rai sir is there from Udaipur. He'll be talking about minor oral surgery procedures. Then for prosthetics, Dr. Moez Kakiani is coming from Bombay. So a lot of people are there. Dr. Ajit Shaligram is speaking on endo. So 2 days of scientific gathering, plus you will have a trade show, the Jaipur Dental Show. So
now we can finally welcome you back. In 2023, we are inviting you all to Jaipur Dental Show and International Scientific Summit, where innovation meets excellence in the world of dentistry. 2 days of exhibitions, scientific sessions, unparalleled networking opportunities with the world's leading figures in dentistry, all taking place in one of the most beautiful heritage cities of the world. Don't miss the chance to be a part of this extraordinary event. Register now and secure your spot at the Jaipur Dental Show. We look forward to welcoming you on December 2nd, 3rd, 2023. See you soon.
So I invite you, all of you, you can go online and just register yourself because this is an idea event. So everyone from all over the country is invited for this. So you can just go online, or you can connect with any IDA members, executives there. So thank you very much. I hope you had something to take back home, and that will increase your thirst for doing better dentistry in future. And thank you for all the oral surgery department of Nims for arranging such a beautiful and program.
Thank you, sir. Thank you, sir.
Thank you, sir, for enlightening us and sharing your experience. Now, I would like to call upon stage Dr. Mohammad Shahnawaz, Senior Training and Technical Manager of iFix Company. Till the time PGs are getting live demonstration from Dr. Mohammad Shahnawaz, I request faculty members of Nims Dental College and our guest speakers to have lunch. faculty members, staff members, please have lunch.
A very good afternoon to all of you. I'll just start with a brief introduction of myself. My name is Dr. Mohammad Shahnawaz. I am a graduate from Manipal College of Dental Sciences, Mangalore campus. I graduated in the year 2009. So initially I was into private practice for 6.5 years. After that I started with the corporate sector. So initially I worked as a training and education manager in Noble Biocare. Then I had a stint in Bio Implants, and since 2019 I'm working as training and technical manager with iFix Implants. So a very big thanks to the faculty of Nims for giving us a chance to come over here. Our mentors, Dr. Narendra, Dr. Nishant, we have a long-standing relationship with them. And to all of you, the future of dentistry, for coming and spending some time. So this is a very critical time, I understand. So I won't be taking much of your time. I'll just introduce myself. I've introduced myself. I'll tell you some about our system and the company, the history, and then we can disperse for the hands-on later on. So the concept of iFix is made in India. So we are making in India, but we are making it for the world. If you want to shine like the sun, you have to burn like the sun. So the machinery, the metal, everything, what we are doing contemporary to all the international brands. So even though we are making in India, we are making it to the world. We have started exporting also, and with your support, we want to become a global brand. So just a brief history. So we are part of Kamal Engineering, which is a giant in hydrocarbon industry. So they wanted to enter into medical devices. So we have our Kamal MedTech, under the aegis of which we are manufacturing cardiac stents as well as dental implants. This is the manufacturing facilities, the different manufacturing facilities they are having. This is the medical division in Faridabad. And all of you are welcome. Anytime you are in Delhi NCR, please let us know. You can come and visit the facility and you can see with your own eyes, because seeing is believing. All the eminent doctors who have visited our facility, they were really happy. Some of them have been to facility abroad also. And they were happy with the standards we are maintaining. So this is the cardiac brands which we are having. We are making cardiac stents, and iFix the dental brand. So how the brief history, how it started. It started as a Government of India project, CISR. So they back in 2005, there was dental implant industry was just starting. It was in the nascent stage, but they foresee, and which came true also, in future it will become a huge industry. And there was no indigenous company. Everything was imported. So they gave the project to IIT Delhi to develop it, the design and development, and Maulana Azad, who gave the clinical inputs, and the clinical trials were done in Maulana Azad itself. So these are the necessary license for selling any medical device in India, and we are ISO 13485 compliant, which is highest for any medical device manufacturing company in India. This is the European certificate CE, one of the most difficult license to obtain. We obtained it in 2020, and due to the pandemic, it got delayed. And even the European guys who came to visit our facility, they were quite surprised seeing the standards being maintained by Indian company, which they said is abreast with other leading and European companies. This was the basic implant which the IIT Delhi started with, and they did the clinical trials with this implant. So it was a mounted implant at that time. Coming to the material, as Dr. Narendra and Dr. Nishant were mentioning, the material is of very high importance. The material which we are using is grade 5 ELI. So commercially pure grade 4 is the most commonly used. This material gives a better strength. The mechanical strength, the tensile strength, and the yield strength is maximum for this medical grade of titanium. Plus we are importing it from USA Carpenter, the leading medical grade provider company in the entire world. Any leading company, it can be Noble Biocare, Strawman, they are procuring their titanium from this company. And the best part of this material is the crack propagation. The most common error which is obtained while torquing an implant, sometimes if we apply a bit extra torque, it can fracture at the collar. But grade 5 ELI, since it is a alloy, it has introduced alloys in the voids, which checks the propagation of any crack. So for any fracture to happen, a crack has to travel from one end to the other. So in this, it checks the propagation of collar fracture better. Since till date, 2014 till date, we have not got a single case of collar fracture. This is due to the material IIT Delhi has chosen. It is also referred as grade 23, and ASTM F136 is the industrial grade. So it is a material of choice in dental, orthopedic, cardiac and neuro departments, because in thinner cross section it provides more strength. TI AL6 V4 is the formula. So these are the different testing which IIT Delhi has done to go to the animal trial and ultimately the human trial stage. Fatigue testing, torsion testing, everything was done in-house by machine specially procured by IIT for this project. So these are the contemporary systems which were taken in as controls while do the Nobel Biocare, Zyve. So Sri Ram Institute of Industrial Research, Chennai, they were our partners for the animal trials. In New Zealand, implants were inserted, and then after 6 weeks and 12 weeks, the histomorphic and CT analysis were done. After 12 weeks, the animal has to be sacrificed according to the ethical committee. So these are the cross sections of CBCT in which you can see strands are growing after 6 weeks and after 12 weeks. Around the collar region, there was a very good spurt of cortical bone strands. So this is the data. After 6 weeks, it was 25%, and after 12 weeks, it was 80%, which gave to the conclusion that the surface is conducive for bone growth and bone deposition. This is the gamma certificate. After each and every batch is gamma irradiated. It is done through our partner lab, Sri Ram Institute in New Delhi. It is a government of India enterprise in which they are working 24/7. We have to send our material over there. Then the gamma radiation is done, and if a certificate is provided at which value it was irradiated. So normally 25,000 plus kilogauges it's there, and after that it is completely sterile for human use. So there are various patents we are having, an Indian patent and US patent. We are on the only Indian company which has a implant with design which has a US patent against its name. So this is the facility. We have 50,000 square of medical manufacturing area and 20,000 feet of clean rooms, which are sterile rooms under which the final aqueous cleaning and packing is done. We have state-of-art clean rooms. The machines which we are using are Swiss Tornos, which are gold standard for any medical device company or any precise engineering involved. This is the implant. So we have a single prosthetic platform. So unlike other systems in which you have to maintain separate inventories, in this we have a single prosthetic platform, so you don't have to maintain different inventories for different diameter of platforms. The sizes which we have, the diameters 3.5, 4, 4.5 and 5. All similar prosthetic components, the same prosthetic components can be used across the platforms. We have a 12-degree Morse taper. So this system is compatible with Noble Active narrow platform. And we have a SLA surface. SLA stands for sandblasted, large grit, acid etched. So we have a forward buttress threads which help in better dissipation of the forces. And we have given a coronal bevel on the top so that more volume of coronal bone can be achieved. And our prosthetic systems have an inbuilt platform shift, so the soft tissue volume can be increased. So we are normally, most of the companies, they are having a two-stage acid etching. IIT Delhi introduced a third stage of acid etching. A third acid was introduced, so the titanium oxide formed on the layer of the surface of the implant has more stability, which leads to more better osseointegration. And we are using ultra pure water for our final aqueous cleaning, which is a multi-stage using different ultrasonic frequencies. So we have a dual connection, internal hex plus a conical connection. The diameter of the conical connection is 2.25 mm. So this is the size matrix we are having: 3.5, 4, 4.5 and 5. The implant lengths are 6.5, 7.5, which are available in 4 diameter onwards. And then we have 8.5, 10, 11.5, 13 and 15. This is a surgical kit. It has been discussed by Narendra sir also. So we have inbuilt stoppers. So we have the pilot drill, the 2.0 mm drill, the lance drill for punch cut. Then after the after the pilot drill, which goes the entire length, if you want to make any lateral correction, the Linderman drill can be used for making any lateral correction, buccal lingual, according to the correction if it is required after taking an IOPA plus the visual examination. We have stoppers. Stoppers help in the predictability of your treatment, because if you have a stopper, you can never overshoot, because sometimes if you would have noticed when you are using a rotary for doing a root canal, sometimes it gets sucked inside. But in this we have a stopper, so you can never over prepare. Under preparation can always be corrected later on. Then we have cortical drills, in which the collar region can be defined. If you have a very dense bone, in that case the cortical bone will not allow implant to go completely inside. So you can use in the collar region, you can use a cortical drill, so it can define the collar region and you can easily place your implant inside. Then we have given 3 paralleling pins, so after the pilot drill you can check the parallelism with the adjacent implants or the adjacent teeth. Then we have given you 4 implant drivers, 2 machine ones, short and long, and 2 ratchet ones. Then they are the hex drivers, so for a prosthetic phase or surgical phase, both the components are given in the kit, so you do not have to rely on the sales manager or anyone for the both of the phases. This drill, the apical 1 mm, the taper, that is not included in the total length. That is done so that you can take the implant subcrestally. So whenever you are placing any length of implant, you have to add 1 mm to your drilling protocol. So this is a sequence of the drill. We start with the lens drill, then we go to the 2 mm drill, the pilot drill. If any correction is required, the Linderman drill is used, then the taper drill for your completing your osteotomy according to a diameter of implant you have chosen, and finally the implant. So as Dr. Nishant was talking, like the pitch is in one complete rotation, how much mm you go inside the bone. So the pitch of our previous implant iFix, the pitch is 1 mm. But if you want to go for a more aggressive implant, you require more primary stability. If you require, we have this iFix Pro. In this, the pitch is more than double of most of the seismology systems. It is 2.6 mm. In one single rotation, you will go 2.6 inside the bone. So this is given if you need more primary stability and you want to under prepare the osteotomy more, you want to conserve more bone. In this cases, this implant is given. The connection, the hex of iFix and iFix Pro is the same. So all the prosthetic components can be used with each other. The sizes available are 3 we are currently working on that. We are trying to bring the same prosthetic platform, so you do not have to maintain a different inventory. 3.5, 4, 4.5, 5 and 5.5. These lengths are available, these diameters are available, and the length is 7, 8.5, 10, 11.5, 13, 15, 18 and 20. 18 and 20 are available only in 3.5 and 4. This is the prosthetic portfolio. So temporary abutments, just in case if you are achieving a torque of minimum 35 NCM while placing the implant, you can give an immediate temporary crown which is off occlusion, so that the patient cannot bite on that tooth. This because despite of you telling the patient, counseling the patient not to eat from the area, the patient is invariably going to eat from the area. So you always have to give it off occlusion. So it is available in hex and non-hex. Non-hex is for multiple implants if you are planning to give. Bridging. Then we have healing abutment. Healing abutment is given in the healing phase stage after the surgery and before the loading of the implants. So what is the time required for healing of the bone? It is 3 months for the mandible and 6 months for the maxilla. So for that period it is given, so it avoids the second stage surgery. If you plan to give that cover screw, just covering the implant, then you will have to do a second stage surgery. And if you want to avoid that, but if the implant is stable, only in that case you can give the healing abutment. So all of our prosthetics, they are in 2 diameters, 4.15 and 5.2. So 4.15 is normally for 3.5 and 4, so you can get the profiling, and 5.2 is for your 4.5 and 5. But since we have a single prosthetic platform, you can interchange them also as per your convenience and requirement. And they are available in different lengths, body lengths and collar lengths, so that you can give in different clinical scenarios according to the thickness of the gingiva. The maximum torque is 5 to 8 NCM because ultimately you have to remove the healing abutment. Healing abutment is not going to be there forever. So 5 to 8 NCM is the maximum torque because sometimes if you over torque, removing it at the time of the prosthetic phase becomes a challenge. These are impression copings, open tray, closed tray. So if you are giving multiple implants, in that case open tray is used. And if you are giving 1 or 2 implants, then both can be used, either closed tray or open tray. Then comes our shoulder abutment. In this, the collar heights are in different lengths. So according to the thickness of the gingiva, you can opt for these. They are available in hex and non-hex. Then we have the angle abutment. So in our stock only, we have 2 types of angle abutment, 15 degrees and 25 degrees. The maximum torque of the abutment screw is 35 NCM. Then comes for your loss work technique, the UCL abutment, the castable. They can be casted with cobalt chromium. So these are also available. These can be also customized up to 15 to 17 degrees. Then comes your tie base. For your anterior requirements, you can use these. So these have least of the metal components. So in this case, they can be used with noble metal like zirconia or pressables like lithium disilicate. These are customizable pre-mill bars if your angulation requirement is more than 25 degree. So in this case, you can see the connection. The connection has been made by the company. So there is going to be no casting shrinkage. And you can make a customized abutment for your patient up to around 40 degrees. But it can be used only in labs having Aurum machines. The pre-mill machines, they should be of Aurum. They are available in 2 diameters, 10 and 14. Like since it's a digital age, so digital scanners are coming. So in that case, you can directly transfer the STL files of impression. So conventional impressions are not required. For that, you will be requiring FCAN body that are also available in our portfolio, and it is also available in the ExoCAD, the digital library, which are with most of the labs. So you can do your digital scans and send the STL files to your labs, and directly they can mill it and send it. So your transportation time and charges are also saved. Ball abutment, as Nishant sir has also mentioned, so these can be used if there is an angular divergence of between the 2 implants. If up to 30 degrees there is a divergence, you can use these locator abutments. They come with the respective housing and the silicone caps. Then are the locator abutments. So these can cater of angular divergence up to 40 degrees. If there is divergence of 40 degrees between the 2 implants placed, you can use our locator abutments. They also come with the silicone rings. So ball abutments, they come with a black one for the processing part, for your impression taking part. Then the pink one, if you require lesser retention or high retention, the clear or the white caps can be used. In locator abutment, they come with one extra. The pink one for low retention, the white one for medium retention, and the purple one with high retention. Then we have got multi-unit abutments, the straight one, 17 degree and the 30 degree. So this is the workflow. Nishant sir has also explained. Implant, then you can either place a cover screw or a healing abutment. Otherwise, you can directly go with the multi-unit abutments, angled or the straight one, 17 or 30 degree. Then in some cases, if you want to immediately convert an existing denture to a temporary, you can use our temporary abutments, temporary multi-unit abutments, and convert your existing denture for a temporary this thing. So this phase also helps in training of the patient and also getting to know what are the specific requirements of the patient during the healing phase. Then we have the analogs and then the final casting rings. So since when we entered into the market has lots of Korean systems. So some of the doctors they wanted a system which will be compatible with the Korean system. So we have the K connection also, known as Asphyx. So this has a pitch of 2 mm. So this is also a very aggressive system. And it also has a bevel on the top and the coronal portion to maximize the volume of the bone. These are the implant sizes available, 3.6, 4, 4.5 and 6. The lengths are 7, 8, 10, 12 and 14. This is a surgical kit, is similar to that, just we have added 2 more drills to accommodate the 6 mm implant. These are the prosthetic solutions available. We have multi-unit, both straight, 17 and 30. In this, we also have a CCM base, the cobalt chrome base. So in this, the advantage of this cobalt chromium base castable are that the casting shrinkage can be avoided. Then we have our locator abutment, ball abutment. Then we have our stock C abutment. Angle 15 and 20 are available in this system also. So these are individual systems. We have cover screw. We have a single cover screw, single implant analog, because since it's a single prosthetic diameter, we do not require multiple cover screws and implant analog. So inventory is reduced in this regard. Then we have our healing abutments. They are same, available in different collar heights and body lengths. Prostate components, we have the temporary abutments, we have open tray, closed tray. So according to the clinical scenario, if it's a single or two implants, you can use our closed tray. Otherwise, in multiple implants, and some people also prefer using open tray in single implants also. So according to your preference, you can choose. Then we have a C abutment, our stock abutment. Straight one, it is also available in different color heights, 1, 2, 3 and 4. Angle abutment, they are available in 15 and 25 degrees. We have a completely plastic one also, castable, and we have a CCM base also. According to your preference, you can choose. Tie base for your aesthetic requirements. We have entire portfolio similar for our all-in-4 solution, the multi-units. Over dentures, we have ball abutment and locator abutment. They are also available in different collar heights. Bone graft also we are having, it's an alloplast material. So we have BCP, it has 25% tricalcium phosphate, beta tricalcium phosphate, and 75% hydroxyapatite. The porosity is 60%, which enables the osteoblast to travel inside the graft and do bone deposition. The pore size is similar to the size of the osteoblast, 300 to 500 micrometer. We have a high mechanical resistance, 3 MPa. So what the company recommends, if the defect is mild to moderate and you do not plan to give a bone membrane, you can mix the graft with blood. It becomes a sticky mesh because it's cohesive, and you can apply on the defect and properly suture the gingiva. It's not mandatory to give a membrane. And the resorption, it's a slow resorbing, 20% in 1.5 years. So it is available in different granule sizes, 0.1 to 0.5, 0.5 to 1, and 1 to 2. It's also available in blocks and cylinders also. So these are the histological signs showing new bone formation. Then we have a faster resorbing also, 100% tricalcium phosphate. The porosity is same, 60%. The mechanical resistance is also 3 MPa. And the resorption time is 20% is resorbed around 5 to 6 months. And it's 100% resorbable. Both grafts are 100% resorbable. They are also available in the same granule and blocks and cylinders. We have got our single piece implants also, PCX. So they are available in 3.6 diameter, and they are available in lengths 8, 10, 12, 14, 6, 17, 20, 23 and 26. This is our compressive implants. It's a cross between the two, the conventional two piece and the single piece. It is also having treated threads. So this was from my side. If you ever have a doubt, I have my colleague Mr. Mohi Sharma with me. He's your local boy. If you ever have anything, he's a quite experienced guy. Any of your requirements can be fulfilled by us. So we, as an Indian company, we will request all the companies which have succeeded. It can be Noble Biocare, Ostem. Their home dentists, they supported them, and then they became global. We have also started an effort. We are almost completed for 5 years now. We have got a lot of support from our Indian dentists, Nishant sir, Narendra sir. They have always supported us in this endeavor. We also request for your support and your feedback. If there is something which you can, suggestion you can give, it is feasible. We have our own R&D team, and whatever suggestion is given to us, we always try to look into it, and if possible, we do introduce it into our system. Service-wise, we try to provide the best service. We have a local guy over here, so we'll be really happy to hear from your side whenever you have any requirement. You can remember us, and I would like to thank your patience and your time you gave to us. Thanks a lot. Thank you.
Thank you so much, sir, and thank you for supporting us to organize this workshop. Now, I would like to call upon stage Dr. Nishant Gupta, sir, to give live demonstration to the students.
अंडे ही मिल सकते हैं, अंडे में आ जाओ। ये लाइट आगे 12 ये वाली लाइट नहीं कोई बात नहीं। माइक की जरूरत है ना, माइक वो ऐसे वो यूट्यूब वाला माइक वो डेमो शुरू हो गया। लैपटॉप है ना, फुल यूट्यूब का जो अपना जो टेलीकास्ट इस पे जा रहा है उसको खोल दो। लैपटॉप पड़ा है, लैपटॉप पड़ा है। अंदर बाहर वाले
पूरा खा पी के आके मैंने भी कुछ नहीं खाया। मेरे इधर भी है। हाँ ना अभी तो क्रांति निकाले तो प्याले में दोनों नहीं बजाने
लाइट बंद कर बोले बंद कर
क्या हुआ? कितना बड़े चाहिए? छोटा एक्सीडेंट चल जाएगा क्या? छोटी एक्सीडेंट चल जाएगा क्या? नहीं वो तो बहुत लगा। अच्छा वहाँ के लिए वहाँ तो भी चल रहा था। हाँ एच डी में है क्या? नहीं मेरे पास छोटी सी है। वो यहाँ से यहाँ 1 मीटर का है। तो इस लैपटॉप को वहाँ लगा देने की दिक्कत है? कौन सा?
नहीं वो तो इधर से अच्छा इधर लगा दो।
और ये यहाँ पे दिखाना ही है ना। ये केबल सपोर्ट नहीं कर रहा
ना तो एक बार केबल अगर है तो दे दो।
दो एक बार है। क्या करना है? कनेक्टर एक बार एच डी में केबल कहाँ लगाएगा?
वहीं लगाऊंगा डायरेक्ट, वहाँ से नीचे बैठ के कर लीजिए।
अरे मेरे लाइव जरा इधर है।
नहीं, इसमें ये वाली केबल चाहिए, ये वाली केबल करनी
वो वाली लंबी नहीं है, मेरे ये लगा हुआ ना पूरा लैपटॉप से।
नहीं, यहाँ से यहाँ तक कर जाएगा ना। मेन कहाँ है, स्विच कहाँ पर है? मैं ये केबल कहाँ से कहाँ तक जा रही है?
वो तो यहाँ से तो वहाँ तक है।
पूरी केबल है ये?
हाँ शायद, इसको बताओ।
पूरी एक केबल है?
ये केबल कहाँ से लगा है? इसका कहाँ है?
ये प्रोजेक्टर की है।
प्रोजेक्टर से यहाँ तक आया?
हाँ, अब मैं इसको दिखाने के लिए प्रोजेक्टर से वहाँ नीचे दे दूँगा लैपटॉप पे, वहाँ चल जाएगा। समझ रहे हो?
वैसा भी कर सकते हैं।
छोटी केबल है क्या आपके पास? इसको ऐसे पकड़ना पड़ेगा, सपोर्ट मिलेगा।
है छोटी केबल लेंगे।
ठीक है। ये देखिए
नीचे कैसे पहुँचेगा? इस तीसरी केबल ऊपर से नीचे कहाँ से जाएगी? आई नहीं। नहीं आया। केबल लगा।
अरे वो छोटा है, वो नीम्स में ऐसे यहाँ पे ऐसे कदर नहीं कोई चीज़ बस।
कैसे लगाएंगे?
छोटा केबल है शायद।
छोटा है तो जाएगी।
और वो स्टूल पे रखेगा आकर के, वो बैटरी बचे इसका चार्ज खत्म है तो
चालू है शायद।
हाँ कम जाएगा। वो नहीं जा रहा है, वहाँ बंद कर रखा है।
हाँ बंद कर।
वो होल्ड पे रखा है, उनको बोलूँगा चलाने के लिए तब चलाएंगे। कितने टाइम में चलेगा? सर एक से लगा, मैं कैमरा एक बार बंद करके हो गया। हेलो, एक मिनट फ़ोन कर देता हूँ सर, एक सेकंड बोल देता हूँ। हाँ चालू कर दो सर, स्टार्ट। स्टार्ट वो कर दिया, सेकंड कर दिया। कंप्यूटर बंद होगा। चालू कर दिया सर, चालू हो गया। एक बार हम तो खुल के देख कर आप चेक करो ना एक बार। मैं कैमरे पैन कर रहा हूँ, नहीं हो रहा है, कुछ शो नहीं हो रहा है। जी सर, चलो हाँ ठीक, उधर से उधर से उधर से कलर बार आ रहा है, कोई प्रॉब्लम हो रहा है। इसको देख लो, हो गया हो गया हो गया, ठीक है चलो हाँ स्टार्ट कर दो, स्टार्ट सर। ठीक कुछ सेकंड में ऊपर चले 5 से जो आपको बना के देंगे वो बाद में वो जो चीज़ करने वाला ले जाएगा आपके पास, आपके बच्चों के पास ही हो जाएगा, यूट्यूब पे सही जाएगा। हाँ दो फ्रेम का आगे पीछे होगा, 2 सेकंड का।
Okay, so here we have the kit. This is the kit of iFix. Already Narendra sir had explained, and Dr. Shanawaz also has explained. So all of you have seen surgical kits, implant surgical kits. Everybody has seen. So I need not go into the detail. All of you know that there are osteotomes with different sizes to increase the width of the osteotomy. Now what we have today is the implant size of 4 and 7.5. So what we do with the iFix kit, they have 7.5 mm stopper. So what I'll do is, first I use the lancet drill to make just a purchase so that my pilot drills and the subsequent drills do not slip. Usually I keep the speed between 800 to 1000 RPM. So initially this model, though it is a dentulous one, I'll just show you how is one straight implant with straight multi-unit, one angulated implant with angulated multi-unit. So with the lancet drill, we'll be making the purchase point. The purchase point can be straight. It need not be at an angle. Even if you are doing an angulated implant. So now I've switched to 2 mm drill. Switch to a 2 mm drill with the 7.5 mm stopper because we are lag हो रहा है, lag हो रहा है।
आप दोनों इसी पे कर दो फाइनल, इसे लाइन मतलब जब भी आ जाए ना इसी जगह छोड़ दो।
अरे इस पे हाँ
तो डायरेक्ट इसको उससे कनेक्ट कर दें, लाइव मानी जाएगा यूट्यूब
नहीं,
यूट्यूब बंद कर दो।
अच्छा
डायरेक्ट ही
कर दो, कम से कम पब्लिक को दिखे तो चले।
हाँ यहाँ पर लोगों को दिख नहीं रहा, कोई वहाँ देख रहा है नहीं देख रहा,
कोई बात नहीं।
अच्छा
कोई बात नहीं,
यूट्यूब बंद करवा दो।
अपनी मेन ऑडियंस तो यही है, इनको तो दिखाना जरूरी है। डायरेक्ट ही कर दो, कोई बात नहीं। अब देखिए चलिए अब कौन सा है
डिले इतना चल रहा है कि लाइव में नहीं सोच रहा।
हाँ बिल्कुल तो इसको कर लो,
लाइव प्रेजेंटेशन तो कहीं